Hello, my dear doctors. Welcome back. This is Dr. Azam here, your faculty of anatomy at Prabladder. A very good morning to all of you. And now we are going to continue with our discussion of anatomy. And especially this is for the students who are actually preparing for Ini-Cet exam. So we're going to continue our discussion of LRR Ini-Cet right now. We are already done with the part one of this one, where we have actually completed a majority of the neuroanatomy part. And now today I'm actually going to complete the remaining topics of the anatomy. And you know very well our planning, I'm going to deal with like topic by topic here. And this session is mainly like the PYQ based as well as the very high yield questions of Ini-Cet. So please pay attention here. We're almost at the end of the neuroanatomy, but of course we are doing the most important part of the neuroanatomy. That is, we are dealing with the brainstem syndromes. That is midbrain, pontine as well as the medullary syndromes over here. Yeah, a very good morning everyone here. I'm able to see your chat box, your responses over there. Very good morning to everyone here. So without any further delay, let's get started right now, my dear friends. Let me just go like one slide back here, and let me first of all tell you about the midbrain, the transverse section of the midbrain. Now, yeah, I'm fine. Of course, thank God, touch wood, like my health is fine. The other day, suddenly in the middle of the session, the very strange reason I can say, if down the line in my life, if someone asked me a question like which was the strangest thing during your classes, I would say that one of the day I was taking LRR Ini-Cet exam, Ini-Cet LRR on YouTube, and suddenly in the middle of that, I need to stop the class just because of hiccups, continuous hiccups, something strange. So everything is fine. Yeah, I'm okay right now. So very good morning to everyone. Let's get started right now. Okay. So now, first of all, let me show you here the transverse section of the midbrain. Now, in the transverse section of the midbrain here, what is going to happen? Ventrally, there will be a depression here. There is nothing but interpeduncular fossa. And dorsally, there will be colliculi. You'll be actually having the colliculi. And this time we are taking the section at the level of superior colliculus. The difference will be when you take the section at the level of superior colliculus, you'll be able to find the third nerve here. Whereas at the level of inferior colliculus, you'll be able to appreciate the fourth nerve. So right now we are taking the section at the level of superior colliculus. And of course, in the middle, you'll be actually having the aqueduct of Sylvius. Now that aqueduct of Sylvius will be an important landmark. Why? Because whatever part that you find behind the aqueduct, that will be the tectum part. Right in front of this one here, this will be the tegmentum part. And in front of that, this will be the cerebral peduncle. Of course, it has to be the cerebral peduncle here and the cerebral peduncle on the other side. That's the reason why in the middle it is interpeduncular fossa. In between the two peduncles, you're having interpeduncular fossa. Now, apart from that, when you are taking the section at the level of superior colliculus here, at the same level, you'll also be able to find a big nucleus here appearing red in color. That is your red nucleus. And in the cerebral peduncle, you'll be able to appreciate this gray matter, which is referred to as substantia nigra. In front of that, there'll be white matter that is referred to as crus cerebri. And that crus cerebri we're going to divide to three parts, and exactly in the middle third it will be having the pyramidal tract, which is also referred to as your corticospinal tract, the descending tract. Fine. Then apart from that, my dear friends, also remember the three lemnisci. You'll be able to appreciate the medial lemniscus, as well as the trigeminal lemniscus and the spinal lemniscus on the lateral side. And we can easily remember that the spinal lemniscus has to be towards the lateral side only. Why? Because it is a continuation of lateral spinothalamic tract. Now, one more lemniscus, the fourth one, the lateral lemniscus is not visible here at this position. Why? Because the lateral lemniscus, which is actually a part of your auditory pathway, it is going to continue along with the inferior colliculus itself, and that's the reason why you won't find that at the level of superior colliculus. And that itself is also an important MCQ. Yes, probably it can be asked in the exam. Which lemniscus cannot be seen at the level of superior colliculus? That will be the lateral lemniscus. Now, once you are able to recall all this, the transverse section of the midbrain over here, and now, my dear friends, let's go ahead with the midbrain syndromes. Now, the midbrain syndromes here. Now, I think already I told you in the last session also, that is in the part 1 of the LRR, that majority of the things we are actually already written here in the slides here, so that we don't waste our time in writing the things and all, because it's all about like last resort revision here. So let's have a quick revision in the mind instead of just simply writing again and again. Fine. Now, welcome here. Now, in this diagram, now first of all, imagine that this much part of the midbrain is actually involved here. I mean to say the third nerve is involved here, number 1. The corticospinal tract is also involved here, number 2. And as well as there will be the upper motor neurons of 7th nerve also involved here. Now, if these parts are involved, then what is going to happen? If the third nerve is gone, absolutely it will lead to, like, that third nerve palsy. Third nerve palsy with that classical down and out eyeball, the constriction of the pupil, blah, blah, blah. I hope you all know that very well. Third nerve palsy. And of course, whenever the nerve will be involved, please remember that it will be always ipsilateral. Nerve will be supposed to be the lower motor neuron, and when it is lower motor neuron, of course, it will be on the same side. Don't even think about that one. So the moment you come across the nerve is injured there, of course, what is the side which will be involved, sir? Ipsilateral part will be involved in that one. Corticospinal tract, it's a descending tract. If it is gone, of course, it is going to carry the motor supply. If it is gone, of course, it will lead to paralysis. But is it ipsilateral or contralateral? Now, please remember that corticospinal tract or pyramidal tract is going to cross. There will be pyramidal decussation, but that will take place at lower medulla. And right now we are at midbrain here. So from the midbrain, it is going to pons, then to the medulla, and in the lower medulla, the crossing will occur, and the other side muscles will not be able to be supplied. That is the reason why it will lead to contralateral hemiplegia. And if upper motor neurons of 7th nerve are involved there, of course, it will lead to facial paralysis of lower half of the face on the contralateral side. If a patient is coming with all these three things here, ipsilateral third nerve palsy, contralateral facial palsy in the lower half of the face, and the contralateral hemiplegia, yes, remember, the patient is actually suffering with Weber's syndrome. This syndrome is actually referred to as Weber syndrome. Now, the next one, if this much part of the midbrain is involved here, yes, then what is going to happen? You can very clearly see third nerve is involved. It will lead to ipsilateral third nerve palsy. A red nucleus will also be involved here. Remember, red nucleus is the one which will be actually connected to your basal ganglia. If that is gone, it will lead to contralateral chorea along with the resting tremors. Medial lemniscus, remember, it is actually the continuation of dorsal column tract, fasciculus gracilis and cuneatus. If that is gone, it will lead to contralateral loss of touch, pressure, as well as, like conscious proprioception and all those things. And then, yes, the trigeminal lemniscus. Trigeminal lemniscus, it is actually coming from your trigeminal nerve. Of course, it is the one which will be carrying the sensory supply from your face. So there will be loss of pain and temperature from the face. And then if the spinal lemniscus will be involved, yes, of course, it is a continuation of what? Lateral spinothalamic tract. Lateral, we remember that as large spinothalamic tract. And that is the one which is going to carry the pain and temperature from the body. Now, if all these things will be happening here, yes, of course, the patient is suffering with what? With syndrome. This syndrome here will be actually referred to as your Benedict syndrome here. Benedict syndrome here. So in Benedict syndrome, the patient is going to come to you with the ipsilateral third nerve palsy with the contralateral chorea. Please remember that one. Now, suppose if this part of the midbrain is actually involved, in which third nerve is involved, leading to third nerve palsy. And then this is actually the superior cerebellar peduncle. I hope you all know very well. Midbrain is connected to cerebellum with the help of superior cerebellar peduncle. And if this one is gone, of course, cerebellum, it will lead to what, guys? Ataxia. contralateral ataxia along with the intentional tremors. So ipsilateral third nerve palsy as well as the contralateral gait ataxia, this syndrome is referred to as the North-Nagel syndrome. Now one more thing, behind this superior colliculi here, you'll be actually having the pineal gland here. And sometimes there'll be what is happening here, pinealoma will occur. When pinealoma will occur, the size of this one will actually increase and that is going to compress the superior colliculi. And superior colliculi, yes, concerned with the visual reflex. That is why it is going to impair the vertical gaze. Fine. And therefore it will lead to that classical sun setting sign. And this condition is actually referred to as your peri-nod syndrome. Peri-nod syndrome is हम कहते हैं sir. In this manner, in a very simple manner, sir, in one diagram we are done with all the syndromes over there: Weber syndrome, Benedict syndrome, North-Nagel syndrome, and peri-nod syndrome. Let's have a revision once more here. If a patient comes to me along with the third nerve palsy, there is contralateral hemiplegia, Weber syndrome. Along with third nerve palsy, if there is contralateral chorea, then it will be Benedict syndrome. Along with the third nerve palsy, if there is a contralateral gait ataxia, then it is North-Nagel syndrome. North-Nagel syndrome, guys. Remember like that. So along with the third nerve palsy, if you see that combination, I hope now the things are becoming easier for you. Moving on to the pons here. First of all, when you take a transverse section of the pons here, this is the ventral aspect of this one, and this one here will be the dorsal side. Okay. Now, if you're going to just draw an imaginary line in the middle and divide that into like two parts over there, then this part is actually referred to as the basilar part here. And this basilar part is the one from where the corticospinal tract here. The corticospinal tract will be passing from here, sir. Then apart from that, there will be the sixth nucleus here and the sixth nerve coming out from here. This one here will be your abducens nerve here, sir. But what about the seventh one? The seventh nucleus is present like more anteriorly, and then it is going to take a turn around this sixth nucleus and come outside here. So this is the seventh nucleus here, and this one here will be your facial nerve. A little lateral to that one, there will be the eighth nerve coming out from here. So this one here will be the vestibulocochlear nerve here. Fine. So 6, 7 and 8 nerve, they will be present at the pontomedullary junction in the same order. Now, because the seventh nerve is going to take a turn here, that is the reason why there will be elevation formed here that is referred to as facial colliculus. Remember, facial colliculus, it will be formed by the seventh nerve taking a turn around which nucleus? It is formed by that sixth nucleus there. Fine. And just lateral to that, we'll be having 8 nucleus. And because of that, one more elevation is formed just lateral to that one. And that is nothing but your vestibular area. I hope you're able to recall everything. We have discussed about that in the floor of the fourth ventricle on the dorsal aspect of the brainstem. Now, once you have got an idea about the transverse section of the pons here, let's see the pontine syndromes here. Now, in the pontine syndrome, first of all, suppose if this much part of the pons is actually involved here, where you can clearly see the sixth nerve is gone. If sixth nerve is gone, I told you nerve, don't even think about that one. It will be always ipsilateral and it will lead to convergent squint. I hope you all remember SO4, LR6 and rest all by 3. LR6. Lateral rectus will be supplied by the sixth nerve. If sixth nerve is gone, lateral rectus muscle is gone. So therefore, the eyes will be actually showing the convergent squint. And then the seventh nerve. If seventh nerve is gone, of course, it is supplied to the muscles of facial expression there. It will lead to ipsilateral facial paralysis. And corticospinal tract, again, the same thing. The crossing is going to take place in lower medulla. We are still in the pons. That is the reason why it will lead to contralateral hemiplegia. And all this together it is known as the Millard-Gubler syndrome. So convergent squint, ipsilateral facial paralysis, and the contralateral hemiplegia, nothing but the Millard-Gubler syndrome. Similarly, if this much part of the pons will be involved, this one will be actually referred to as the pontocerebellar angle syndrome. Pontocerebellar angle syndrome. Please remember the reason here. The reason here is it is occurring due to the acoustic neuroma. Now, what is involved here? Seventh nerve is involved here. Of course, it will lead to ipsilateral facial paralysis. Eighth nerve will also be involved here. Eighth nerve, vestibulocochlear. It will lead to progressive deafness actually. And then along with that, even this will also be involved here. That is nothing but your cerebellar peduncles are also involved, which are going to connect with the cerebellum there. Of course, it will lead to what? Ipsilateral ataxia will occur. So all these things are going to happen in the pontocerebellar angle syndrome. Now we all know very well, right in front of the pons, there will be an artery passing from here, basilar artery. And if this basilar artery stroke will occur, if there is a stroke in the basilar artery here, it will of course lead to what this pontine syndromes here. But suppose if the main trunk of the basilar artery is gone here, the main trunk is gone here. Okay, so therefore it is going to affect bilaterally here. So therefore it will lead to what bilaterally the Babinski sign will be actually positive. Please remember that point also. It has been asked in the exam. If the main trunk of the basilar artery is gone, it will lead to bilateral Babinski sign, which will be positive over there. Now welcome to the transverse section of the medulla oblongata. When you take the transverse section of medulla, remember it's a beautiful butterfly shape. Behind the medulla oblongata, this one here will be the floor of the fourth ventricle here. So this one here will be the fourth ventricle here. And this elevation in the front here will be referred to as pyramid, as it is formed by pyramidal tract. Just lateral to that, this is olive and olive, and you can clearly see it is formed by the inferior olivary nucleus over here. And we know very well between the pyramid and the olive, the 12th nerve, hypoglossal nerve, is going to come out from here. The 12th nerve, hypoglossal nerve, will be coming out from here. Fine. Now let's do one thing here. Let's see the medullary syndromes here. Of course, if the medial part is getting affected here, this is referred to as the medial medullary syndrome here. And this medial medullary syndrome, it is also known as the Dejerine syndrome. Whereas if the lateral part of the medulla oblongata is getting affected here, then it will be of course the lateral medullary syndrome, which is also very famously referred to as a Wallenberg syndrome. And many a times in your exam, there will be a question coming from the Wallenberg syndrome also. Now, first let us deal with the medial medullary syndrome. Of course, 12th nerve will be involved. I told you whenever it is nerve, it has to be ipsilateral. And 12th nerve, hypoglossal nerve, is the one supplying to all the muscles of the tongue. And that is the reason why when you ask the patient to protrude the tongue will be deviated onto the same side. So there will be ipsilateral tongue deviation. Along with that, even medial lemniscus is also gone. Now medial lemniscus, it is actually the continuation of dorsal column tract. Again, the same thing, the fine touch, proprioception, of course the conscious proprioception, along with stereognosis, and all those structures will be actually, all those functions will be actually lost on the contralateral side. In fact, the corticospinal tract here, pyramidal tract, is also gone, and again it will lead to what's a contralateral hemiplegia. Now some students will be questioning here, sir, we are already in the medulla oblongata here, why it's again contralateral? Remember, that's the reason why I was stressing on it will be crossing at the level of lower medulla. The pyramidal tract is going to cross at the level of lower medulla. That is the reason why lato is still contralateral hemiplegia. All these things will be seen in the medial medullary syndrome. Now, what about the lateral medullary syndrome here? The most characteristic feature here, remember, the fifth nerve, that is your trigeminal nerve, sensory nucleus will be involved. Trigeminal nerve is going to carry the sensory supply from the face. So there will be ipsilateral loss of pain and temperature from the face. And then from here itself, the spinal lemniscus is also going to pass. Spinal lemniscus, the continuation of lateral spinothalamic tract. Last spinothalamic tract is going to carry pain and temperature from the body. So loss of pain and temperature from the face on the same side, ipsilateral side. Loss of pain and temperature from the body on the contralateral side. Okay, and this condition is actually referred to as crossed hemianesthesia. That is something really important about the Wallenberg syndrome. So loss of pain and temperature on the same side here in the face, and loss of pain and temperature on the opposite side of the body. And of course, it is known as the crossed hemianesthesia, which will be seen in the Wallenberg syndrome. That is a characteristic feature, and by that you can easily identify in the MCQs there, guys. Okay, so I hope the brainstem syndromes are like crystal clear right now. Now moving on to the next topic here, the cerebellar cortex. Now in your exams, the cerebellar cortex is very much important here, my dear friends. And many a times we have observed that in your PYQs, they are giving this image of the cerebellar cortex, histological image here. Now remember, in the cerebellar cortex, there are totally like 3 layers. And in these 3 layers, we'll be having 5 different types of cells. Now first, remember the names here. The outermost layer here will be the molecular layer. The middle layer here will be the Purkinje layer. And the innermost layer here will be the granular layer. Molecular, Purkinje, and the granular layer. Now in the molecular layer, you'll be having the stellate cells and the basket cell. In the Purkinje layer, there will be Purkinje cells, and in the granular layer, you'll be having granular cells as well as the Golgi cell. So we are done with the 3 layers as well as 5 different types of cells. Now the first point to remember here, stellate cells will be inhibitory, basket cells will be inhibitory, Purkinje cells will also be inhibitory, Golgi will also be inhibitory, but granular cells are the one which are excitatory. So from here we can say that cerebellar cortex is actually the largest collection of inhibitory neurons. Cerebellar cortex is actually the largest collection of inhibitory neurons. All the neurons will be like inhibitory only for the granular cell. Granular cells will be excitatory. Now, out of all these cells, can you please tell me in this diagram you are able to identify which cells here? Of course, we are able to identify this big cells which are the Purkinje cells here. So remember 2 points regarding the Purkinje cells. They are the largest among all the cells and they will be like flask shaped cell. And what I have observed in your Ini-Cet exam, always they'll be giving this histological image of cerebellum and there will be arrow mark to identify this cell. And of course, the answer will be the Purkinje cell. So what I'm trying to tell you is that you should be able to identify the Purkinje cells here, guys. Yes, I'm observing there in the chat box, you're answering correctly. So they're largest and flask shape, and image based question they're always giving there, guys. That is your Purkinje cell to identify. Fine. Perfectly done. Now welcome to the deep nuclei of the cerebellum. There are like totally 4 deep nuclei in the cerebellum, and how to remember them? Doctors ate good food. They're actually arranged in the same order. Doctors D actually stand here for dentate nucleus, and then E stand for emboliform nucleus. Good food. G stand for globose nucleus, and then food F stand for fastigial nucleus. So doctors ate good food. Now why I'm asking you to remember this order here? Why? Because in the exam they have asked which is the medial most one. Of course the medial most one will be fastigial nucleus. And which one will be the lateral most one here? The dentate nucleus. And dentate nucleus will be the largest one. Apart from that, remember the shape also. It is crumpled paperback shape. Even this has been asked in your exam. It is crumpled paperback shape, the dentate nucleus. Now, globose and emboliform together, they will be combined, and combinedly they are referred to as interpositus nucleus. Globose and emboliform will be sometime combined together and they'll be referred to as interpositus nucleus. So all these points regarding the cerebellum has to be revised before going to the exam, sir. I hope all these things is very much clear here. Now we are done with all the high yield topics to be revised in neuroanatomy here. Let's go to the next important topic, that is head and neck topic here. I hope all of you are comfortable here. So we have discussed like almost every important topic in neuroanatomy. Now after that, let's go ahead with the next important topic, that is head and neck topics. One of the hot favorite topics in Ini-Cet exam, that is about the cranial foramen and the structure passing from here. Especially nowadays they are giving this diagram where you have to identify the cranial nerve. Okay. Now this is the cribriform plate here. Passing from the cribriform plate will be the cranial nerve number 1, olfactory nerve. Now this one here is optic canal. From the optic canal there will be optic nerve passing from here. Till here it is very much easier. Now please remember this nerve here will be actually the third nerve. That is your oculomotor nerve. And then this nerve here will be actually the fourth nerve here, sir. This is the fourth nerve here. That is your trochlear nerve. Please be very careful here. That is the reason why I'm writing with a separate color there. So that is your third nerve and fourth nerve. Now why is that fourth nerve here? Why? Because remember, just now I told you if this one is your midbrain here, then what is going to happen? The fourth nerve is going to have a dorsal origin and come from here. Okay, it's coming from the behind there, fourth nerve. So that is your fourth nerve. And if you anytime find a nerve ascending up from this slope here, there is a slope there that is referred to as clivus. And if you find a nerve ascending up from that slope, that one will be your sixth nerve, that is abducens nerve here, sir. That is abducens nerve. After this, anyone will be easily able to identify. This is the largest one, that is your trigeminal nerve. And then passing from the internal acoustic meatus will be the seventh nerve and the eighth nerve, the facial and the vestibulocochlear. The jugular foramen here, there will be 9th nerve, 10th nerve and the 11th nerve. And from the hypoglossal canal, there will be the hypoglossal nerve. That is your 12th nerve there. So all these nerves easily anyone will be able to identify. I require my students to have your focus on number 1, the oculomotor nerve here and the trochlear and the abducens nerve here. So this is something like really important to identify. Now once you are able to identify all these nerves here, welcome. There is one important fissure, there is nothing but superior orbital fissure. Now, between the lesser wing and the greater wing of the sphenoid bone, you'll be having the superior orbital fissure. Fine. Now, what are the structures which are going to pass from the superior orbital fissure? Cranial nerve number 3, and then the cranial nerve number 4, and then there will be the cranial nerve number 6 passing from here. There is your abducens nerve, and all three of them are going to supply to extraocular muscle. Along with that, even the 5-1 ophthalmic nerve branches will be passing from here, the branches of ophthalmic nerve. And the branches of ophthalmic nerve will be three of them. One will be your frontal nerve, another one is nasociliary nerve, another one will be the lacrimal nerve. The frontal, nasociliary and the lacrimal nerve. And of course, along with all this nerve, there will be ophthalmic vein passing from here, sir. There will be two of them. One is superior ophthalmic vein, another one is inferior ophthalmic vein will be passing from superior orbital fissure. All the structures are going to pass from here. But you have to remember that there will be a ring here, tendinous ring of Zinn. Tendinous ring of Zinn here. And you need to learn what are the structures passing inside that and what are the structure passing outside that. And please remember one simple mnemonic here. Remember LFT, that is your left is left outside the ring. Now what is that left here, sir? One is your lacrimal nerve, another one will be the trochlear nerve, another one will be the frontal nerve. So lacrimal, trochlear and the frontal, LFT, left is left outside the ring of Zinn. That's all, you'll be done. Remaining all the structures are going to pass inside the ring here. And of course, you're able to find the ophthalmic veins also outside here. The superior ophthalmic vein and inferior ophthalmic vein are also present outside the ring of Zinn. Now moving on to the next foramen here, that is jugular foramen. What is going to pass from the jugular foramen? Of course, the 9th nerve, 10th nerve and 11th nerve is going to pass. Along with that, there will be inferior petrosal sinus here and sigmoid sinus. Now please look at me here. Suppose if this is the jugular foramen here, inferior petrosal sinus here and the sigmoid sinus, both of them will be passing from here. After passing, they're going to combine and form together the internal jugular vein. That is the reason why this foramen is actually referred to as your jugular foramen here. Fine. So please remember all the structures in order. So first you'll be having inferior petrosal sinus, then 9th, 10th and 11th nerve, and then we'll be having sigmoid sinus. Apart from that, one more important thing to remember, out of the three nerves present over here, which nerve will be present in a separate sheath here? That one will be the 9th nerve. 9th nerve will be present in separate sheath, whereas the 10th and 11th together, they are present in the common sheath and they are together going to form vago-accessory complex. I hope you all remember. Together they are the one which are going to form your vago-accessory complex here, VAC. Now once this is done here, let us move on to the another very important concept here, that is about the pterion. You all know very well pterion is actually a H-shaped suture here and it is formed between the four bones. Number one, this one here will be the frontal bone. This here will be the parietal bone. This here will be the squamous part of the temporal bone and this one here will be the greater wing of the sphenoid. Now basically what you have to remember here is point number one, pterion is corresponding to what? It is corresponding to which fontanelle? It is corresponding to anterolateral fontanelle here. Fine. Now this is something important for your Ini-Cet exam. Recently also one question was asked from here. What are the relations of pterion? What are the deep relations of pterion? Now here what is going to happen? Number one, middle meningeal artery will enter inside and then there will be anterior division passing from here. There will be like two division of that one. So anterior division, or which is also referred to as frontal division of middle meningeal arteries passing from here. Of course, you will also have your brain here, and in the brain, this fissure here will be nothing but your sylvian fissure, also known as the lateral sulcus. So between the frontal lobe here and the temporal lobe here, this one here is lateral sulcus, which is also referred to as sylvian fissure. So the stem of sylvian fissure, the beginning of that one is also present here. So the sylvian fissure or the lateral sulcus, the stem of that is also present near the pterion, which was asked recently in the Ini-Cet exam. And if that lateral sulcus is present here, what is the artery passing in that one? Of course, it will be the middle cerebral vessels will also be present inside that. And then remember, pterion is actually formed by the greater wing of the sphenoid, but just inside the pterion, there will be the lesser wing of the sphenoid. So let us repeat all these relations of the pterion once more here. It's worth repeating. Yes, there will be anterior division or frontal division of middle meningeal artery. And then there will be middle cerebral vessels here. And then sylvian fissure or the lateral sulcus. And then the lesser wing of the sphenoid here. Now the clinical anatomy associated with this one, suppose if there is a hit or trauma at the pterion, then what is going to happen? Of course, what is the artery present here? That is your middle meningeal artery. This will be ruptured. Rupture of middle meningeal artery will actually lead to epidural hemorrhage. And that you can very clearly see here, it is convex shape, that biconvex shape hemorrhage, or we can also call it as like, that idli shape hemorrhage and all. And in this, of course, the person will be suffering with lucid interval. Please remember all these points. Very much important topic. Pterion has been completed here, sir. Now welcome to the hot favorite topic of Ini-Cet examiner, that is muscles of mastication. If you ask me, sir, please tell like one question or one definite question that is going to be asked in your Ini-Cet exam, I would say muscles of mastication. And they don't get tired of asking a question from here. So definitely in every exam, there'll be one question from muscles of mastication. There are totally 4 muscles of mastication. First, you should be able to identify this one here will be the masseter muscle attached to the ramus of the mandible from outside. This one here will be the temporalis muscle, and then the lateral pterygoid and the medial pterygoid. Remember this very carefully. The muscle which will be actually attached to the capsule of temporomandibular joint here. This one here will be the lateral pterygoid muscle, and another one here will be the medial pterygoid. Again, that is also getting attached to the ramus of the mandible here, but from the inner side. That is also attached to the ramus of the mandible from the inner aspect. So masseter here, temporalis here, the lateral pterygoid here, and the medial pterygoid, all these 4 are the muscles of mastication. Now, let me tell you the first MCQ here itself. Temporalis muscle, the posterior most fibers are more horizontal here. So now because these fibers are like more horizontal, when they are going to contract, they are going to pull the mandible behind, and that is why it is a retraction of the mandible here. And this vertical fibers here are going to pull the mandible above, that is nothing but elevation of the mandible there. Elevation of the mandible. So basically we are having 2 functions of temporalis muscle. It is helping in retraction as well as elevation. If both the options are given, please remember elevation will be better than retraction. Already given in the exam. Temporalis muscle will be helping in, yes, 2 things, elevation as well as retraction. Remember, elevation is a better option. Now I'll tell you like 5 points here. The questions will be asked from these 5 points only. What is a nerve supplying to all the muscles of mastication? Of course, that will be the mandibular nerve. That is your 5-3. Which muscle will be helping in opening the jaw? Opening the jaw is done by lateral pterygoid muscle. Please remember L for lateral pterygoid and L for lowering the jaw. Okay. Retraction of the mandible is done by temporalis. Just now I told you. Most commonly involved in trismus. Trismus is nothing but the locked jaw. Locked jaw, medial pterygoid muscle will be involved here. And the accessory muscle of mastication here will be buccinator muscle. That is your buccinator muscle, guys. If you remember these 5 points here, you will be able to solve all the questions possible here. Now here, don't think that, Azam sir told about the depression of the mandible. He did not tell about elevation. Remember, for depression of mandible, only one muscle is required. That is lateral pterygoid. The rest, all the 3 muscles are required for elevation of the mandible. In this manner, you're actually going to remember this one. Moving on to the next topic right now, muscles of tongue. Muscles of tongue are divided into intrinsic and extrinsic, but you just got to remember about the extrinsic muscles of tongue for your exam. Number 1, from the genioid tubercle here, from the mandible here, there is a muscle going into the tongue, and this one here will be genioglossus. There's a styloid process here. From here, this muscle going to the tongue, styloglossus. Below here will be your hyoid bone here. From this to the tongue will be the hyoglossus. And from the palate into the tongue, that is your palatoglossus. Now there are 3 important MCQs here. Out of all the muscles of tongue, which is the largest muscle of the tongue, that is genioglossus. And this is the muscle which is also referred to as the safety muscle of tongue. Why? Because this is going to help in protrusion of the tongue. And because it is helping in protrusion of the tongue, it is preventing the tongue from falling back. Preventing the tongue from the falling back. That is the reason why it will be referred to as safety muscle of the tongue. Now out of all the muscles of the tongue, which is not a true muscle of the tongue, that will be palatoglossus. और इसको याद रखना बड़ा आसान है, उसके नाम में ही लिखा है palatoglossus. It is a muscle of the palate also and muscle of the tongue also. So it is not a true muscle of the tongue. It is a muscle of palate as well as tongue there, palatoglossus. Now one important clinical application here, we know all the muscles of tongue will be supplied by which nerve? That is your 12th nerve, hypoglossal nerve. And hypoglossal nerve except for which one here? Palatoglossus. We know that very well. Fine. So nerve supply to all the muscles of the tongue will be by the 12th nerve, except what? Except the palatoglossus, and that is supplied by vago accessory complex. Every medical student knows this one, right from first year onwards. Now, if you have to test this 12th nerve, if you have to test the 12th nerve here, what you have to do? Ask the patient to protrude the tongue. Now, suppose if my left 12th nerve is gone, if the left 12th nerve is gone, left side muscles will be paralyzed here. Only the right side muscles are working there, and that will be dominant. That is the reason why it is going to actually push the tongue towards the side which is actually impaired. So therefore, whichever side the tongue is actually going to turn, the same side the 12th nerve will be gone. So ipsilateral side the 12th nerve will be gone. Now once you are done with the nerve supply of the tongue, the muscles of tongue, nowadays what I'm observing the pattern in Ini-Cet exam is they are asking about the papillae of the tongue. This is something like really important right now. I want you to please revise this before going to the exam about the papillae of the tongue. So they're asking about the papillae of the tongue. Like 2-3 years back, it used to be mostly about the nerve supply of the tongue or about the muscles of tongue. But nowadays they're asking about the papillae. Number one, you'll be actually having the filiform papillae, and then number two, the mushroom shaped one, that is your fungiform papillae there, and then you'll be also having the circumvallate papillae and then the foliate papillae. Out of this image based question was given actually. Circumvallate papillae, image based question was given. Easy to identify. The upper surface of this one is like more wider compared to the lower surface will be like narrower, and because of the presence of this trench or the groove here, please remember this one here. So by this you'll be able to identify this is the circumvallate papillae. There'll be a trench or there'll be a groove on either side there. By that you'll be able to identify. That is something really important here. Now I'll tell you certain points regarding all this papillae here you have to remember. Now first let me tell you about the circumvallate papillae. Where are they exactly located, guys? Suppose if this is your tongue here, and tongue will be dividing into anterior 2/3 and posterior 1/3, and they are located here. Circumvallate papillae are located here, arranged in that V-shaped manner. So posterior part of the anterior 2/3 of the tongue arranged in the V-shaped manner, that is your circumvallate papillae. Okay, and they are the one which are having circular groove or the trench. That is something important. Now filiform papillae, what are the points to remember? There are 2 points that you have to remember, that there will be no taste buds in this one. They're slender, thread-like and all those things, but there are no taste buds in this one. And one more thing, normally in the oral cavity, of course there will be stratified squamous epithelium in the oral cavity, because we'll be eating and all, there'll be like wear and tear. Wear and tear, you should actually have multiple layer. So there'll be stratified squamous epithelium. But will it be keratinized or non-keratinized? Remember, in the oral cavity, it should be non-keratinized. It should be non-keratinized, but filiform papillae will be having keratinized stratified squamous epithelium. Keratinized stratified squamous epithelium. So these 2 points you have to remember about the filiform papillae. That's all, remaining not that much important. Moving on to the next topic, another hot favorite topic of Ini-Cet examiner, that is deep cervical fascia. Deep cervical fascia. Now in the neck region, you'll be actually having fascia, and that fascia is nothing but the deep cervical fascia, deep fascia of the neck, and it will be in turn having like 4 modification. Now this yellow colored one here, which you're able to see surrounding the vertebrae and the muscles, this is the prevertebral fascia here. Now this is the trachea here, and behind the trachea esophagus. In front of that there is a thyroid gland, and thyroid gland is surrounded by this fascia here. This is pretracheal fascia here. Now this muscle here will be the sternocleidomastoid muscle and sternocleidomastoid muscle here. This one will be the trapezius here, that will be the trapezius here, and you can see that red colored line which is surrounding the entire neck, like a neck band, it is surrounding there, and that layer is splitting and enclosing these 2 muscles, sternocleidomastoid and the trapezius muscle, and that is referred to as the investing layer. This is the investing layer here. And the last and final, the very famous one, this sheath here will be the carotid sheath here. So this is the carotid sheath here. Now let us learn all the important points regarding this each and every fascia here. What are the important points to remember? First of all, about the prevertebral fascia, what is going to happen? Now from the spinal cord, remember, brachial plexus is going to begin from here, and that brachial plexus has to come out. Fine. Now that brachial plexus has to come out of the prevertebral fascia. Is it going to tear the fascia? No. It's going to carry the fascia along with that one into the axilla. Into the axilla there, and that extension is actually referred to as axillary sheath. अच्छा, तो ये सवाल आपके एग्जाम में पूछा गया था कि axillary sheath is the extension of which fascia? So please remember the extension of prevertebral fascia. It is the extension of prevertebral fascia. Now the next one, what is the content of pretracheal fascia? Of course, you are able to see the thyroid gland there. So the content of the pretracheal fascia here will be the thyroid gland here. Now the next one here will be the carotid sheath, and carotid sheath you can very clearly see what is the content of this one. There will be common carotid artery, and of course there will be even the internal carotid artery, but not the external carotid artery. Why? Because external carotid artery is going to pierce that and come outside. It is remaining outside there. So it is not a content of the carotid sheath. It's only the common carotid as well as the internal carotid here. Now, one more thing, there will be even a vein here, that is your internal jugular vein. In between them, you're able to find a nerve here, and this nerve here will be the vagus nerve. That is your 10th nerve. So the common carotid artery, the internal carotid artery, internal jugular vein, along with the vagus nerve, all this will be the contents of carotid sheath. But apart from that, please remember these contents also, there will be like false contents. That is your 9th nerve, 11th nerve, as well as the 12th nerve is also false content. Now, why I'm telling you the false content? Why? Because it is not present inside the carotid sheath throughout the length of that one. They're just present in the upper part of that, the cranial part of that, not throughout the length of the carotid sheath, sir. Now, once you are done with all these things here, welcome to the last and final one, that is investing layer. And for this investing layer, you have to remember the rule of two, sir. Now, what is this rule of two here? It is enclosing the two muscles in the middle here, sternocleidomastoid muscle and the trapezius. Thoda sa upar, it will be enclosing like two glands here, parotid gland and submandibular gland. Thoda sa niche, it will be enclosing two spaces here, that is suprasternal space and supraclavicular. So aise yaad rakh lo, above it is enclosing the two glands here, below it is enclosing the two spaces, and in the middle like two muscles here. So what are the two muscles it is enclosing, sir? Sternocleidomastoid and trapezius. The two glands will be parotid and submandibular gland, and the two spaces below will be the suprasternal and supraclavicular. Apart from that, there will be two ligaments, that is stylomandibular and sphenomandibular, and then there will be two pulleys actually. There is one for the digastric muscle, digastric pulley, and the omohyoid pulley, sir. Fine. अब यहाँ से सवाल क्या पूछा गया था? What is the question asked in your exam? So please remember, parotid gland is actually enclosed by this investing layer. That is why whenever there will be mumps will be very much painful. Why they are painful? Why? Because of unyielding nature of the parotid gland. Unyielding nature of that investing layer covering the parotid glands. तो ये जो investing layer उसको cover करता है, it is actually very much fibrous, very much, it's not like elastic and all, it is not allowing the gland to expand. So when it is not allowing, because of that unyielding nature, what is going to happen? The mumps will be actually very, very much painful here. That question was given in the exam. अब चलिए आगे बढ़ते हैं, sir. Let's take the sagittal section. Now once you take a sagittal section here, again the same thing. This yellow colored fascia surrounding the vertebrae here will be the prevertebral fascia. And then just outside the pharynx here, there is one more fascia present here. And this fascia, which is green colored one here, this one here will be the buccopharyngeal fascia. Now in between the prevertebral and buccopharyngeal, there is one more fascia present here. This one here will be the alar fascia. There is alar fascia. Now if there are three fascia, common sense my dear friends, there will be like two spaces between them. अगर यहाँ पर तीन fascia है, तो out of that there will be like two spaces between them. But my dear friends, please observe very carefully the alar fascia. The alar fascia is going here, going here, going here, and finally that is getting attached with what here? Buccopharyngeal fascia. It's getting attached with what? Buccopharyngeal fascia. Now first remember the name of this space here. This space is actually found behind the pharynx. ये pharynx के पीछे होता है. So therefore this space is referred to as retropharyngeal space. Now this retropharyngeal space, is it an open space or it is a closed space? Remember, of course it is a closed one. Now this space here was actually asked in the exam, and this is referred to as the danger space. Danger space, why? Because you can clearly see this space is open here. और अगर यहाँ कोई infection वगैरह कुछ होता है तो that infection is not going to limit to your neck region only. This infection will further continue down, continue down, continue down into the mediastinum of the thorax. That is dangerous. That is why it is referred to as the danger space. This was asked in the image based question. Please take care about that one here. Okay. Now there was a question regarding the Berry's ligament also. What is this ligament of Berry? It is the one which is going to connect your thyroid gland to cricoid cartilage behind. That is the ligament of Berry. It is one of the modification of your pretracheal fascia only. And because of this, what is going to happen, whenever you're going to consume something, eat something, then the thyroid swelling is going to move with deglutition, with swallowing. And that is because of which ligament? Berry's ligament. Keep this very, very clearly in your mind, my dear friends. Remember, because of this Berry's ligament, what is going to happen? If there is a thyroid swelling, that swelling is going to move with the swallowing, with deglutition. Is it okay? Yes, of course. It is the thickening of the pretracheal fascia only. Very good, Dr. Imran. Yes, from the base of the skull, it is going to the mediastinum. Now moving on to the next one, we are now going to discuss about the mandibular nerve in detail, my dear friends. Mandibular nerve, nothing but one of the branch of your trigeminal nerve. That is your 5-3 here. And remember, this nerve is actually a mixed nerve. What do I mean by the mixed nerve here? It will be having both the components. That is your sensory as well as the motor component here. So I'm just writing S here and I'm writing M here. Sensory and motor component is present here. Now this mandibular nerve is going to pass through a foramen. That foramen is referred to as foramen ovale. I hope you all remember the mnemonic male here. M stands for mandibular nerve, A for accessory meningeal artery, L for lesser petrosal nerve, and E for emissary vein. So mandibular nerve is going to pass through the foramen ovale. Now first of all, you're actually having the trunk of the mandibular nerve here. And that trunk will be finally dividing into two divisions finally here. One of the division here will be the anterior division and another division here will be the posterior division. Fine. Now the first point that you have to remember is trunk. Trunk, there are like 4 important points to remember. What are the 4 points to remember about the trunk? The trunk of the mandibular nerve will be supplying to one of the muscle of mastication. And that muscle of mastication is medial pterygoid muscle. Already asked in your exam. So then what about the remaining muscles of mastication here? They are taken care by the anterior division. It will be supplying to the masseter muscle, the temporalis muscle and the lateral pterygoid muscle. Masseter, temporalis and lateral pterygoid are taken care by the anterior division. So trunk will be supplying to only the medial pterygoid. Point number 2, the same nerve is supplying to two tensor tympani muscle. Another one will be the tensor valli palatini muscle. Apart from that, the trunk is also giving rise to a branch and that branch will be passing behind here. And this one here will be the nervus spinosus. What is the name of this nerve here? This is nervus spinosus here. Now this nervus spinosus is going to pass from which foramen here? I hope you remember when we learned about the cranial foramen, there we learned about ROS. Foramen rotundum will be present here. Then you'll be having the foramen ovale here and then there will be foramen spinosum. So ROS, there will be the foramen spinosum here. Is it okay? So nervus spinosus is going to pass from the foramen spinosum. Along with that one, there will be an artery passing from here and this artery here will be the middle meningeal artery passing from here. So nervus spinosus along with that middle meningeal artery. And the last and final point that you have to remember, the trunk of the mandibular nerve is going to pass through a ganglion here and this ganglion will be the otic ganglion. What is this ganglion here? Otic ganglion. So you got to remember the 4 points regarding the trunk of the mandibular nerve. Let us repeat that again. The trunk of the mandibular nerve is supplying to one of the muscle of mastication, medial pterygoid muscle. That nerve itself is supplying to two tensor tympani, tensor valli palatini. And then it is also giving a nerve that is nervus spinosus. It is going to pass through a ganglion that is otic ganglion. Now after that, already I am done with the anterior division here. No need to worry about that one. Welcome to posterior division. Now this time if you are writing the Ini-Cet exam, I am expecting a question from here. The posterior division will in turn give rise to 3 branches here and we remember them as Ali branches. And out of these 3 branches, definitely one question will be asked in your Ini-Cet exam. Now in these Ali branches, please remember A stands for the auriculotemporal nerve here. Auriculotemporal nerve. And from the name itself, we can understand auriculotemporal nerve is supplying to the skin over the auricle, upper two-third. Upper two-third, the skin over the auricle here, and the skin of the temporal region. As well as the joint here, that is temporomandibular joint, and even the gland. That gland is very much important. Parotid gland here, sir. Parotid gland is the one which will be supplied by your auriculotemporal nerve here. Perfectly done. And you know very well that will be involved in your Frey's syndrome. Frey's syndrome में involved होता है. Then L actually stands for your lingual nerve here. The first point that you have to remember, observe the lingual nerve very much carefully. It's going here, going here, going here, and that is going to pass via a ganglion here. And that ganglion will be submandibular ganglion. Submandibular ganglion. And we know very well lingual nerve is the one which is going to carry the general sensation from the anterior two-third of the tongue. And then I stands for the inferior alveolar nerve here. And that inferior alveolar nerve, from the name itself, we can understand it is the one which will be passing through the lower jaw. That is nothing but your mandible. But the problem here is that we have cut and removed the mandible from here. That is why the inferior alveolar nerve is actually cut here. But remember, that is going inside the mandible. And what is the question possible here? The MCQ that is possible here will be inferior alveolar nerve is going to enter into the mandible via which foramen? That foramen will be the mandibular foramen. Please remember, it will be the mandibular foramen there. Done? Now one more important MCQ here is that if this is your lingual nerve here, please remember that there will be a submandibular gland here. And submandibular gland, the duct of that gland will be actually turning around the lingual nerve. It's going to wind around the lingual nerve. Now in the exam, they'll be giving a clinical question. A person was consuming gutka or some tobacco or something like that. Then what is going to happen? One fine day, submandibular gland resection was done. The submandibular gland was removed actually. Now once you remove the submandibular gland, because the duct is taking a turn around the lingual nerve, which nerve is more prone to injury here? That answer will be what's a lingual nerve. So during the submandibular gland resection, whatever story that they are telling, sir, we are not concerned about that. The main important thing is submandibular gland resection. In that, what is a nerve which is most commonly injured? That has to be your lingual nerve here. Okay. So all these three early branches, remember one MCQ for that one. I repeat once more here. Auriculotemporal nerve supplied to the parotid gland, that will be involved in Frey's syndrome. And lingual nerve that will be injured in the submandibular gland resection here. An inferior alveolar nerve that is going to pass through a foramen. That foramen is referred to as the mandibular foramen. Please remember these three MCQs here. Question will definitely come from here, sir. And of course, how can we forget? Facial nerve and the palsy of that one. UMN and LMN palsy of the facial nerve. Recently in your Ini-Cet exam, there was a question asked about accumulation of food in the cheek, between the cheek and the gums here. The food is accumulated here between the cheek and the gum here. Then which muscle will be involved here? Of course, your buccinator muscle is gone. I mean to say the lower half of the face is actually paralyzed. If the lower half of the face is only paralyzed here, remember that is due to which one? UMN lesion. Upper motor neuron lesion. There will be paralysis of only the lower half of the face, that too on the contralateral side. And if there is LMN paralysis, LMN lesion here, then what is going to happen? Complete half of the face will be paralyzed here. Both the upper half and lower half of the face, complete half of the face will be actually paralyzed here. So done. Now for now in the class, it looks very, very easy, my dear friends, that upper half of the face is gone, lower half of the face is gone, or complete half of the face is gone. That looks very much easier. But in exam, they will not give you this exact words, upper half, lower half and all. They will actually give you certain hints there. You have to identify. Now, for example, if lower half of the face will undergo paralysis, then what is going to happen? There will be drooping of angle of the mouth. The angle of the mouth will be drooping here. And from there, the saliva will be dropping there, guys. There will be dropping of saliva from there. Then apart from that, what is going to happen? There will be accumulation of food in between the cheek and the gums there. Why? Because these muscles are gone. You're not able to move the food out from there. Is it okay? So accumulation of food between the cheek and the gums over there. So remember these 3 points here. Let's repeat that again. Okay, now drooping of the angle of the mouth here, and then dribbling of saliva from here, and then accumulation of food here. Then what about the upper half of the face? If this is paralyzed, then what is going to happen? I'll not be able to raise my eyebrows like this here. And there will be no formation of horizontal wrinkles here on the forehead. No horizontal wrinkles on the forehead there. Fine. And that is indicating, acha, the person is suffering with, the paralysis of upper half of the face. If both the things are mentioned, then complete half of the face is gone. Nothing but LMN lesion. Keep that in mind, sir. Now in this diagram, you're able to see these are the upper motor neurons here, and those neurons are going to come all the way up to the nuclei, and after the nuclei, there'll be actually the lower motor neuron. So please remember, they can also tell you this word in the exam. They can also what they've already given in the exam. Upper motor neuron lesion, these are above the nuclei, the supranuclear, and these fibers are below the nuclei here. That is nothing but infranuclear. Please don't get confused with that one, because always I have seen the students will have the habit of just learning UMN, LMN lesion. Please remember, they can also give you the word as supranuclear and infranuclear also. Next one. Yes, the cranial nerve nuclei and columns. Now, the moment you look at this table here, don't get confused here, my dear friends. There are three columns here, which are motor columns. This one will be actually your GSE, general somatic efferent. And then there'll be special visceral efferent here. And then there'll be general visceral efferent here. These three are like motor columns here. Now, you actually have to catch the important word here. The important word here is general somatic efferent. Now, somatic efferent means it will be supplying to the muscles which are derived from somites. Now, remember in our head and neck here, there are two group of muscle which are actually derived from the somites, extraocular muscle and tongue muscle. So from the somites, there will be extraocular muscles and the tongue muscles. Okay. Extraocular muscle SO4, LR6, rest all by 3. They are supplied by these nerves. So therefore, the third and fourth nerve or their nuclei will be located in midbrain. We know that very well. And the sixth nerve nucleus will be located in the pons. Perfect. Okay. So extraocular muscles are actually supplied. Are you understanding the sequencing here? Extraocular muscles are supplied by third nerve, fourth nerve, and sixth nerve. Their nuclei are located where? Third and fourth nerve nuclei will be located in midbrain. Sixth one will be located in the pons. And then I told you another which muscle here? Tongue muscle. Tongue muscle, they are supplied by hypoglossal nerve. Hypoglossal nerve, the nucleus will be located, of course, in the medulla oblongata. Acha. That means in GSE column, general somatic efferent column, the word somatic is very much important. It is the one, this column is the one which will be supplying to those muscles which are derived from somites. Which muscles are derived from somite? Two group of muscles, extraocular muscles and tongue muscles. Done. Special visceral efferent, this is the one which will be supplying to the muscles derived from the pharyngeal arches. Now, what are the muscles derived from the pharyngeal arches? Remaining all the muscles. Muscles of mastication, the muscles of facial expression, the muscles of larynx, pharynx and palate. And pharyngeal arches, they'll be supplied by which nuclei? 5, 7, 9 and 10. I hope you remember if you have seen my main videos. In my main videos, I already taught you the pharyngeal arches will be supplied by which nerve? How to remember that? Remember 5, 7, 9, 10. The fifth nucleus and the seventh nucleus will be located in the pons here, whereas the 9th, 10th and 11th, it will be located in the medulla oblongata there. And together this nucleus will be referred to as nucleus ambiguous. Even that question has been asked. Nucleus ambiguous is the common nucleus of 9th, 10th and 11th ones. Now after that one, welcome to the GVE column, and this is very much important one. General visceral efferent. Efferent motor supplying to the general viscera. It is the one which is supplying to the smooth muscle and glands. Smooth muscle as well as the glands. So let us remove this column separately here and learn. Okay, so this one here will be your GVE column here, sir. Now GVE column is the one which will be supplying to the smooth muscle and glands, sir. Now first of all, the smooth muscles present inside the eyeball, sphincter pupillae muscle and ciliaris muscle, and that will be taken care by the third nerve. Which nucleus? Edinger-Westphal nucleus. Now from here there will be third nerve here. It will be going and ending in a ganglion, that is ciliary ganglion, and from here the short ciliary nerves will be supplying to the smooth muscles present inside the eyeball. Seventh nerve, actually this is the nucleus. Superior salivatory nucleus belongs to the seventh nerve here. This is belonging to the third one, right? And inferior salivatory nucleus belongs to the ninth nerve there. The seventh nerve will be giving a branch, greater petrosal nerve, that will be ending in pterygopalatine ganglion, supplying to lacrimal gland here. And then one more branch given by the seventh nerve will be the chorda tympani nerve. It is going and ending in submandibular ganglion, and that is supplying to the two glands here, that is your submandibular gland and sublingual gland. Ninth nerve will be finally going and ending into the otic ganglion, and from there it will be supplying to which gland here? Parotid gland. So I told you very, very clearly, general visceral efferent is actually all about the smooth muscle and the glands in the viscera. Finally, what about the smooth muscle and glands present in the thorax and abdomen? All of that will be taken care of by the vagus nerve, and that nucleus will be the dorsal nucleus of vagus. तो अगर आप इसको ध्यान से देखोगे यहाँ पर थर्ड नर्व, सेवेंथ नर्व, नाइन्थ नर्व एंड द 10th नर्व, 3, 7, 9 and 10, that is actually the parasympathetic nervous system, the nerves which will be actually contributing to your parasympathetic nervous system. That is the reason why all these 4 ganglion, ciliary ganglion, pterygopalatine, submandibular and otic ganglion are the ganglions of your parasympathetic nervous system. So many topics will be completed here, sir. Please look at this one, this diagram before going to your exam there. Perfect. Now coming back to the sensory nuclei here, sensory columns. In the sensory column, again the same thing, it will be like a mirror image here, SVA and GVA, special visceral afferent and general visceral afferent. It is about the special sensation and general sensation from the tongue. And from the tongue, the special and general sensation will be finally coming to the nucleus of tractus solitarius. Why the name is given like that? Why? Because you can see in this column, there is no nucleus above this one, there is no nucleus below this one. It is just a solitary nucleus, nucleus of tractus solitarius. General somatic afferent. Somatic, the word is actually about the body wall. Afferent, we are sensing. Body wall, head and neck. And in head and neck, from this body wall here, it will be sensed by trigeminal nerve. And trigeminal nerve, the sensory nucleus is actually the biggest one. It's a big nucleus. You can clearly see it's present in midbrain as well as pons as well as in medulla oblongata. So there are like 3 sensory nuclei. In the midbrain, it is also referred to as mesencephalon. That is why mesencephalic nucleus. In the pons here, this is the chief sensory nucleus. And finally, this one here will be the spinal nucleus. So mesencephalic nucleus, the chief sensory nucleus and the spinal nucleus here. And finally, this is totally a different column here, sir. SSA, special somatic afferent here. And the special somatic afferent, this will be including the nuclei which will be belonging to your ear, that is vestibular as well as the cochlear nuclei. Vestibular nuclei and the cochlear nuclei, and these nuclei are located exactly at the pontomedullary junction. Pontomedullary junction, sir. So in this manner, easily you can actually remember about all the cranial nerve nuclei and their columns, and along with that, we're also done with the 4 parasympathetic ganglions located here, sir. Now welcome to the next concept here. The next concept is actually about the posterior triangle of the neck. We know that very well. It is between sternocleidomastoid here, sternocleidomastoid muscle, trapezius muscle, and this one here will be the clavicle here. Fine. Now between the sternocleidomastoid here and the trapezius here and the clavicle here, posterior triangle. In the roof of the posterior triangle, you'll be having 4 cutaneous. What are the 4 cutaneous nerve here, sir? This is the lesser occipital nerve here. This one here will be the great auricular nerve here. This one here will be the transverse cervical nerve. And this nerve which is actually going above the clavicle, this will be the supraclavicular nerve. Let us repeat that again here. Lesser occipital nerve, greater auricular nerve, and this is transverse cervical, and this is supraclavicular. And along with this great auricular nerve here, there will be the external jugular vein passing from here. It is not the internal jugular, external jugular vein will be actually passing from there, sir. Now, out of all these nerves, remember in your exam, they're asking a lot of questions regarding the great auricular nerve. Point number 1, it runs along with external jugular vein. Point number 2, it supplies to what here, sir? This is something really important. Look at me here. The great auricular nerve is actually coming here. It will be supplying to the skin over the angle of the mandible here, as well as the skin over the lobule of the ear. I can say lower 1/3 of the auricle. Lobule of the ear or the lower 1/3 of the auricle here, sir. Okay, this much part is taken care by the great auricular nerve. Point number 3, remember, a person underwent some surgery here, okay, paroidectomy and all. And after the surgery, one fine morning, he was actually shaving. And while shaving, there's no sensation in the shaving area. If he's not able to sense anything in the shaving area, then what is the nerve involved? The nerve involved will be the great auricular nerve. The great auricular nerve is actually injured there, sir. Okay. Now, point number 4 is that there is nothing but your Frey's syndrome. Now, how come Frey's syndrome is involved here? Remember, the nerve which is getting injured in Frey's syndrome will be the auriculotemporal nerve will be getting injured, sir. I told you very, very clearly just few minutes back, Ali branches. And in Ali branches, auriculotemporal nerve, A for auriculotemporal nerve, and that will be gone in the Frey's syndrome. Fine. Now if it is injured, then now it is trying to regenerate, and while regenerating, remember, it is going to come and join with the great auricular nerve. The auricular temporal nerve is now joining with the great auricular nerve. In normal people like you and me, now what is happening, sir? Whenever we are going to eat something, the auricular temporal nerve will be stimulated, and that is going to stimulate the parotid gland, and parotid gland is going to secrete the saliva. So salivation is occurring in the normal people like you and me right now. But in this person, what is going to happen? The auricular temporal nerve is injured there, and that is going to commonly go and join with the great auricular nerve. Now what is going to happen? If the person will eat something now, the auricular temporal nerve will be stimulating what? Great auricular nerve. And once it is stimulated there, what is going to happen? The person is eating the food, and this part here will be getting red, as well as sweating will be occurring here. So redness and sweating will occur here, and that is why it will be referred to as your Frey's syndrome. So gustatory sweating will occur. So please be very, very clear with 2 points in the Frey's syndrome here. Number one, what is the nerve getting that injured here? Auricular temporal nerve. And that auricular temporal nerve is most commonly going and joining with which nerve, sir? It is most commonly joining with great auricular nerve. So these 2 points has to be like crystal clear in your mind. So all these are the points that you have to learn about the great auricular nerve. Take care about that one. Now another important concept here, what are the structures which are going to pass through the constrictor? Now in this diagram, you're able to see the superior constrictor muscle here and the middle constrictor. Now between the superior constrictor and the middle constrictor, you will be able to appreciate there is a muscle passing from here. That muscle will be the stylopharyngeus muscle. Stylopharyngeus muscle. और मैंने आपको लास्ट क्लास में भी बताया था, स्टाइलोफैरिंजियस मसल को ना स्टाइल मारना होता है, और स्टाइल मारने के लिए क्या चाहिए? ग्लॉस. तो इट इज सप्लाइड बाय ग्लॉसोफैरिंजियल नर्व. These two are going to pass between superior constrictor and the middle constrictor. Now what is the structure passing between the middle constrictor and the inferior constrictor? Remember, this membrane here will be the thyrohyoid membrane, and piercing that will be having the nerve going inside internal laryngeal nerve. What is the nerve? Internal laryngeal nerve. And below here there will be trachea. Behind the trachea there is esophagus, and between them there is a tracheo-esophageal groove. In that groove, you'll be able to find a recurrent laryngeal nerve. So there is an internal laryngeal nerve here, and there is a recurrent laryngeal nerve here. And then along with that internal laryngeal nerve, you'll be having superior laryngeal artery. Why? Because that is going to go above superior laryngeal, and below here there will be inferior laryngeal artery here. That is how you're going to actually remember these structures. It makes sense here. Now finally, what are the structures present above the superior constrictor? Above here, what is the structure present here? Number one, you'll be able to find the auditory tube here, eustachian tube. Along with that, there will be levator veli palatini muscle. And then along with that, there will be like 2 arteries. Please remember the names very carefully here. One is ascending palatine artery. Another one will be the palatine branch of ascending pharyngeal artery. Now all these structures are going to pass above the superior constrictor. Above the superior constrictor over here. I hope this concept is also very much clear. Now, how can we forget that inferior constrictor muscle, sir? Inferior constrictor muscle is in turn made up of 2 muscles from the thyroid cartilage to the pharyngeal raphe, thyropharyngeus muscle, cricoid cartilage to the pharyngeal raphe, cricopharyngeus muscle. These 2 muscles together, that is going to form your inferior constrictor. I repeat again, inferior constrictor is formed by 2 muscles. One is thyropharyngeus, another one is cricopharyngeus. Now between these 2 muscles, there will be a triangular area of weakness, and that weak area is referred to as Killian's dehiscence. And the elderly people, when they are coughing and all, when there is a force applied on the wall of the pharynx there, then there will be a diverticulum coming out from here, and that diverticulum will be referred to as Zenker's diverticulum. And even this image based question was also given here, sir. Zenker's diverticulum. Now the next concept here, we have to learn about the superficial relations of hyoglossus muscle as well as the deep relation also. Now in this diagram, needless to say, this muscle here coming from hyoid bone here, this muscle will be the hyoglossus muscle. And we have to learn what are the muscles, what are the structures going to pass superficial to that one and deep to that one here. Now in this diagram, this nerve here will be the lingual nerve. And I told you just now, the lingual nerve is the one which is going along with the ganglion, submandibular ganglion. You can clearly appreciate here. And of course, there will be a gland present over here, and that gland here will be the submandibular gland. Even that gland is also Superficial here, but which part of the submandibular gland? Remember, deep part. Then after that, you're also able to appreciate here this nerve. And this nerve is the one which is going from below here and supplying to all the muscles of tongue. That is the reason why doctors have named this nerve as hypoglossal nerve. That is your 12th nerve. Hypoglossal nerve. It is going from below the tongue and supplying to all the muscles of tongue, guys. Okay. And then what about this muscle here? This muscle here is coming from styloid process and going to the tongue, styloglossus muscle. Now all the structures which I have written here, all this will be the superficial to the hyoglossus muscle. These are all like superficial relations of the hyoglossus muscle. Now apart from the superficial relation here, what about the deep relation? Let me just write down with another color. Remember two things here. Number one, from the same styloid process, you can see a ligament passing here, and that ligament is going deep to this muscle and attaching to your hyoid bone. That is stylohyoid ligament. Another one here will be that there is a nerve which is passing from here, and this one here will be the ninth nerve. So this one here will be the stylohyoid ligament here, and this one here will be the ninth nerve. And these two structures, please remember, they are going to pass deep to the hyoglossus muscle. So we are done with the superficial as well as the deep relation of hyoglossus muscle. And nowadays there are like two important trending concepts. One is about the tonsillar bed, another one is about the piriform fossa. Now first of all, let's see about the tonsillar bed. In this diagram, this one here will be the tonsil. The tonsil will actually have this crypts here towards the oral cavity here, or towards the medial side we can say. And this one here will be the lateral side. And on the lateral side, the tonsil is actually covered by a capsule here. First of all, you'll be having the capsule. And please remember, the muscle present here will be the superior constrictor muscle. And inside that superior constrictor muscle, you're actually having that tonsil there. Inside the superior constrictor muscle, you're actually having the tonsil there. So this muscle here will be the superior constrictor muscle. And that muscle is having one fascia inside and one fascia outside. The outside one here will be the buccopharyngeal fascia. And the one which is inside here will be the pharyngobasilar fascia. Pharyngobasilar fascia. Done. Now between this capsule here and between this muscle here, there is some space. There is nothing but the peritonsillar space, and there you are able to appreciate one vein here, and that vein here will be the paratonsillar vein. Paratonsillar vein. So these are all the structures that you have to remember in order one by one. So first there will be capsule here, then there will be paratonsillar vein here, and then there is a muscle, and that muscle will be having one fascia inside and one fascia outside. All of them are together going to form that tonsillar bed. Done. Now once you're done with this one, last and final thing will be the piriform fossa, which is also referred to as the fishbone area or the smuggler's pouch. You can very clearly see the piriform fossa on either side of this laryngeal inlet here. Okay now. So this is the piriform fossa over here. Now piriform fossa, what do you have on the medial side? Medial side there will be a fold here, that is epiglottic fold here. And on the lateral side, what do you have here? There will be mucosa which is going to cover that thyroid cartilage. That's like simple. Now the most important thing is on what is located inside that one here. There's a nerve, and this nerve is very much important, my dear friend. Internal laryngeal nerve runs superficially here. So whenever we are eating that fish, the fish bone will go and get lodged there, and we'll be getting some pain. That pain is actually via this nerve only, internal laryngeal nerve. That is very much important. They'll be giving a clinical question about this one there. Fine. And by this, we are done with all the concepts regarding the head and neck topics. So all the higher points in the head and neck topic has been completed here, guys. So we are done with like two important topics here. That is your neuroanatomy as well as head and neck topic here, guys. Fine. We'll take a small break here. We'll take a break for 5 minutes here, sir. And after 5 minutes, we're going to continue. Exactly in 5 minutes, we'll be back. Then we'll continue with the remaining topics, like upper limb, lower limb, and all those things. Welcome back, everyone. Am I audible and visible to all of you? I hope I'm audible and visible to all of you guys. Sure. So we are done with like two important topics here. One is neuroanatomy, another one is head and neck topic here. And after that, now we are going to start with the easier topics now. That is your upper limb and lower limb topic. So first, let's get started with the upper limb topic here. In upper limb topic, without any doubt, the most important thing will be your ulnar nerve, median nerve, and the radial nerve. Now, my dear friends, try to recall here. Ulnar nerve, median nerve, and radial nerve. For all these nerves, I have given one golden rule. The anterior compartment of the arm here will be supplied by musculocutaneous nerve. The posterior compartment of the arm will be supplied by radial nerve. The posterior compartment of forearm is also supplied by radial nerve. The anterior compartment of the forearm is supplied by two nerves. One is your ulnar and median, and the same ulnar nerve will continue here, and the same median nerve will continue here, and will be supplying to the muscles of hand. That is our golden rule. Please remember that one. Now, ulnar nerve, we know that it is going to originate from which cord here? It is going to originate from the medial cord of brachial plexus. And the root value of ulnar nerve will be C7, C8, and then T1. Now, first let us see in the arm here. In the arm, ulnar nerve is actually going from the arm and entering into the forearm by passing behind the medial epicondyle. Now, this is an important point here. What is the nerve which is going to pass behind the medial epicondyle? That is your ulnar nerve. And it is going to enter into the forearm passing between the two heads of a muscle, and that muscle will be the flexor carpi ulnaris muscle. Now, will the ulnar nerve supply to any muscle in the arm? Remember, it is not going to supply to any muscle in the arm. I told you the golden rule very clearly. Anterior compartment is taken care by musculocutaneous nerve, and the posterior compartment is taken care by the radial nerve. So in the arm, it is not supplying to any muscle here. Now in the forearm, remember, the ulnar nerve will be supplying to medial 1.5 muscle. Now what is the name of that one complete muscle? The one complete muscle will be flexor carpi ulnaris and the medial half of flexor digitorum profundus. And then from here, the ulnar nerve is going to enter into the hand. How it is going to enter? By passing superficial to flexor retinaculum. आप इसको ऐसे याद रख लीजिए, ulnar ऊपर. तो ulnar nerve is going to pass above the flexor retinaculum. And there also it is going to pass in a canal, and that canal is referred to as Guyon's canal. Now after entering into the hand, the ulnar nerve will divide into like two branches here. One will be the superficial branch, another one will be the deep branch here. The superficial branch is supplying to only one muscle, that is palmaris brevis muscle here, along with the skin over medial 1.5 digit. Medial 1.5 digit here, sir. And remaining everything will be taken care by the deep branch here. The deep branch will be supplying to the hypothenar muscles here, the lumbrical number 3 and lumbrical number 4 here, and all the 4 palmar interossei and all the 4 dorsal interossei here. And going on the other side, it will be supplying to adductor pollicis muscle. In fact, ulnar nerve will be finally going and ending in the adductor pollicis. That is why it is also referred to as the graveyard of the ulnar nerve. Graveyard of the ulnar nerve. So in this manner, we got the concept of ulnar nerve in a crystal clear manner. Now suppose if the ulnar nerve is injured here near the wrist. अगर यहाँ पर ulnar nerve injured हो जाता है, almost like 15 muscles of the hand will be gone. If these 15 muscles are gone here, it will lead to actually a claw hand here, and this one here will be referred to as a partial claw hand. So the nerve that will be involved in the partial claw hand will be the ulnar nerve. Apart from that, already I said you like regarding the adductor pollicis here. Adductor pollicis is helping in adduction of the thumb, and with that we'll be actually able to hold the book there, and that will be used for testing the ulnar nerve, and that test is actually referred to as book test. If the ulnar nerve is gone, adductor pollicis muscle is also gone, you are not able to hold the book there, then what is going to happen? You will be actually able to hold the book by flexing the thumb. This time it is not by adduction of the thumb, it is by flexion of the thumb, and that is why that sign is actually referred to as your Froment sign. So the Froment sign will be positive there. Now interossei, you know very well, there will be palmar interossei and dorsal interossei. Palmar interossei will be helping in adduction of the fingers, and dorsal interossei will be helping in abduction of the fingers. Okay, so adduction and abduction, abduction here. So please remember that adduction of the fingers, what you're going to do, you're going to give a card and ask the person to hold the card between the two fingers there. Okay, and that test is actually referred as card test here. So for palmar interosseous, you're going to do which test? Card test. Similarly, for the dorsal interosseous, you're going to do the Egawa test. In Egawa test, you'll ask the person to keep your hand on one of the surface and move the middle finger on either side. So if you are able to do the abduction of that one on either side, that means your ulnar nerve is perfect there. So for adductor pollicis, we are going to do the book test. For palmar interosseous, we are going to do the card test, and for dorsal interosseous, we are going to do the Egawa test. Fine. So I told you about the injuries as well as the test with respect to the ulnar nerve, guys. Now moving on to the next one, that is your median nerve. Again the same thing. From the arm, it is going to move into the forearm here by passing between the two heads of pronator teres muscle. There will be like two heads of the pronator teres. The median nerve is going to pass from there. Now, will it supply to any muscle in the arm? Now please remember that ulnar median nerve will not be supplying to any muscle in the arm. I told you the golden rule. Anterior compartment by musculocutaneous nerve and posterior compartment is by the radial nerve. Yes, median nerve is not going to supply to any muscle in the arm there. Now in the forearm, the median nerve will actually give rise to a branch here, and this branch will be the anterior interosseous nerve. Now remember, in the forearm here, these are all the flexor muscles. They'll be arranged in two layers, the superficial layer and the deeper layer. The superficial flexors are taken care by the median nerve itself, whereas the deep flexors will be supplied by anterior interosseous nerve. And then the median nerve is going to pass deep to the flexor retinaculum. And deep to flexor retinaculum, there will be a tunnel, and that tunnel is nothing but your carpal tunnel. So what is the nerve which is going to pass through the carpal tunnel there? That is your median nerve. Median nerve is going to pass through the carpal tunnel there. Now after entering into the hand, it is again dividing into like two branches here. And then this branch here will be actually taking care about all the muscles. Like all the thenar muscle here except the adductor pollicis and the lumbrical number 1 and lumbrical number 2 are taken care by your median nerve here. Fine. Now what about this digital branch and the palmar cutaneous branch? So please be very careful. Palmar cutaneous branch is a branch of median nerve only, but that is going to come above the flexor retinaculum. Median nerve is actually going beneath the flexor retinaculum, but palmar cutaneous branch is going to come above the flexor retinaculum. Now sir, what is the difference between these two here? Remember, I told you just now the little finger and half of the ring finger. This one will be taken care by ulnar nerve, and the remaining 3.5 here will be taken care by median nerve. The thumb, index finger, middle finger and half of the ring finger. Okay, now, so this will be taken care by the median nerve over here. Now in this one, if you learn in depth here, my dear friends, remember the digits here, the thumb here, index finger, middle finger and half of ring finger, this is supplied by digital branch there, and then the palmar surface here will be supplied by the palmar cutaneous branch. Okay, so by this we are done with the entire median nerve topic here, sir. Now for example, if the median nerve is injured here, then these 5 muscles will be actually gone here. Now you ask the patient to make a fist. So he'll be able to make the fist like this here, but this will not be folded. It will remain like this only. There is nothing but pointing index. So what is the nerve involved in pointing index? Of course, median nerve. Exactly the same explanation for hand of benediction also. What is the nerve involved in hand of benediction? That is also the median nerve. Fine. As well as remember, if median nerve is gone, all the thenar muscles will be gone, but only one muscle is working there, that is adductor pollicis. So therefore the thumb will be adducted and lying along with the fingers. So that is why it will be referred to as your ape thumb deformity. So pointing index, hand of benediction, ape thumb deformity, in all of them, which nerve will be involved? Of course, your median nerve will be involved here, sir. And what is the test we are going to do for that one here? Keep the pen here like this and try to touch the pen with the thumb here. Okay, now, and that is done by your thenar muscle, abductor pollicis brevis, and that test is referred to as pen test. So pen test will be actually done for testing the median nerve, guys. So by this, all the points regarding median nerve are done and done and done, sir. Now welcome to the last and final one, that is your radial nerve. Radial nerve, of course, coming from the axilla, then it is going to pass behind the humerus bone here, behind the shaft of the humerus, and this one will be passing in the spiral groove here. And then that radial nerve will be coming on the lateral side of the arm here, right in front of the lateral epicondyle. This is the lateral epicondyle here. Right in front of that, it is divided into two branches. One is superficial branch, another one will be the deep branch. अब मैंने आपको ना already पहले ही बता रखा था, already I told you that radial nerve is the one which will be supplied to your entire posterior compartment here. The posterior compartment of arm, it will be having triceps. In that, you remember from the axilla itself, it is actually giving the branches to long head of triceps and a part of medial head of triceps. Then in the spiral groove, it will be giving the supply to the remaining medial head of the triceps along with the lateral head of the triceps as well as the anconeus muscle. Then the next landmark will be the lateral side of the arm. And at the lateral side of the arm, it will be supplying to brachioradialis, ECRL as well as the brachialis muscle. ECRL actually stand for extensor carpi radialis longus. Extensor carpi radialis longus. After that, welcome to superficial branch. Of course, it is the one which will be supplying to the skin of dorsum of the hand here. The skin of the dorsum of the hand here. Whereas the deep branch. The deep branch is going to pierce one muscle. Listen this very much carefully here. It is going to pierce a muscle. That muscle will be supinator muscle. After piercing that supinator muscle, it is going behind. And the moment it is going behind, the name changes. And now it will be known as the PIN, posterior interosseous nerve. And that will be supplying to all the muscles of the posterior compartment of forearm, nothing but your extensor muscles, guys. Perfectly done. Now, if the radial nerve is injured, then what is going to happen? After learning about the entire topic, let us see about the injuries right now. If the radial nerve is injured here, extensors are not going to work and I will not be able to keep the wrist here. Wrist, drop. What is the nerve involved? Radial nerve. Saturday night palsy. What is the nerve involved? That is a radial nerve. Crutch palsy. Okay, a handicapped person is using the crutches. What is the nerve that is getting compressed here? That is also your radial nerve, guys. So wrist drop, crutch palsy and the Saturday night palsy, in all these conditions radial nerve will be actually involved there. But important question here is, one question was given where there will be finger drop but not the wrist drop. Wrist is normal, only the finger drop is taking place there, and that nerve involved will be the PIN. If this PIN is gone here, only the extensor digitorum, which is going to extend the digits, that will be gone. So remember, yes, of course, Dr. Imran, absolutely correct. The wrist finger drop but no wrist drop, the nerve involved will be PIN, the posterior interosseous nerve. I hope the concept is very clear here. And take my words, out of these three nerves, ulnar nerve, median nerve and the radial nerve, definitely one question will be asked in your exam. Okay, अब चलिए आगे बढ़ते हैं सर. Let's go ahead right now. Anatomical snuff box. On the lateral side, you'll be actually able to see the two tendons here, and one will be the abductor pollicis longus. Another one will be the extensor pollicis brevis. On the medial side, there will be only one tendon, and that one tendon will be extensor pollicis longus. Now, once you are done with these boundaries here, the floor is very much important. Now, in the floor of the anatomical snuff box here, you'll be able to find the styloid process of the radius, scaphoid bone, trapezium, as well as the base of the first metacarpal. All this will be present in the floor of the anatomical snuff box. Out of that, the scaphoid is very much important. Why it is important? Why? Because already it was given in your exam. A person comes to the clinic after falling on the outstretched arm. A person falls on the outstretched arm. And then he comes to the clinic with the pain in the anatomical snuff box. The pain is due to fracture of which bone? Of course, the most commonly fractured will be scaphoid. And what is the content of the anatomical snuff box? You are able to see here very clearly. There is an artery here, and that artery will be the radial artery. Please be careful. I'm telling you radial artery, not the nerve. Now, another very important concept, nerves related to humerus. Remember, there are totally like three nerves which are actually related to humerus. Number one, passing behind the surgical neck of the humerus. This nerve here will be your axillary nerve here. Then the nerve which is going to pass in the spiral groove here, this one will be the radial nerve here. And the one which is going to pass behind the medial epicondyle here, that will be the ulnar nerve. So there are like totally three nerves which are related to the humerus bone here, sir. Now, axillary nerve, it will be supplying to only two muscles in our body. One is your deltoid muscle, another one will be teres minor muscle, sir. Be careful, it is minor. Axillary nerve will be supplying to deltoid muscle and teres minor. Please underline that minor there or highlight the minor there. Why? Because मुझे पता है आज minor होगा, 2 दिन के बाद में teres major हो जाएगा और एग्जाम में तो ऐसे ख्यालात आते हैं कि ऐसा मसल होता भी है क्या, ठीक है ना? तो please be careful there, it is teres minor. So deltoid and teres minor will be taken care by axillary nerve, sir. Now suppose if there is a fracture at surgical neck of the humerus, so therefore axillary nerve is gone. Therefore deltoid will be gone. और deltoid अगर पैरालाइज हो जाएगा तो क्या हो गया? Our shoulder is actually beautifully appearing rounded here because of deltoid. Deltoid muscle is giving that rounded contour to the shoulder. So it will be no more rounded. This will become flat in here. The flat shoulder, yes, it's due to the paralysis of this deltoid muscle. You can actually appreciate in this diagram here. Acha, axillary nerve is not only supplying to these two muscles here. Axillary nerve is also supplying to the skin over deltoid. And the skin over deltoid here, you'll not be able to sense anything, and that is referred to as a regimental batch sign. A regimental batch sign. Yes. So perfectly, we are also done with the axillary nerve concept here, sir. Now, these are all the important topics to be revised here in upper limb here, sir. Now, similarly, welcome to the lower limb topic right now. Now, in the lower limb topic also, let me tell you the golden rule. Same thing as I told you in the upper limb topic, let me tell you in lower limb topic also. Now in the lower limb, for example, if this is the thigh, all the muscles in the thigh here are divided to like three compartments. There will be anterior compartment of the thigh, then posterior, and then you have muscles on the medial side, medial compartment of the thigh. Then come down to the leg region. In the leg region, again you're having three compartments, that will be anterior, posterior, and the lateral compartment. So in the thigh, you'll be having anterior, posterior, and medial compartment. And in the leg, you'll be having anterior, posterior, and the lateral compartment. Then finally, the foot. In foot, you don't have any compartment there. Now, all the muscles in the anterior compartment of thigh will be taken care by femoral nerve. Medial compartment of thigh will be supplied by obturator nerve. Whereas the posterior compartment of thigh, they'll be supplied by tibial nerve. Tibial nerve. So God has made our body exactly in the same manner, upper limb, lower limb, exactly same planning here. In the upper limb, entire posterior compartment is supplied by a radial nerve. Similarly, entire lower limb in the entire posterior compartment will be supplied by the tibial nerve. Sir. What is left out in the leg region now? Anterior compartment of leg will be supplied by deep peroneal nerve, and lateral compartment of leg is supplied by superficial peroneal nerve. So once you are done with this entire golden rule here, now my dear friends, welcome to the most important one, sciatic nerve. Again, I'm telling you once more here, definitely you can expect like one question from here in your Ini-Cet exam, sir. Now, what is the sciatic nerve? It is made up of two nerves, sir. One is your tibial nerve, another one will be the common peroneal nerve. That is the reason why it's going to originate from L4, L5, S1, S2 as well as the S3. So sciatic nerve is not like a single nerve. It is made up of tibial nerve as well as the common peroneal nerve, and it's going to originate from L4, L5, S1, S2 and S3. Now, first of all, the sciatic nerve is going to exit from which foramen? Greater sciatic foramen. So from the pelvis, it's going back into the gluteal region. From the pelvis here, it is going back into the gluteal region here via greater sciatic foramen. Above piriformis or below piriformis muscle? So please remember it is going to pass below piriformis. As I told you, this is your sciatic nerve here. Yes, it will be having two components, tibial and the common peroneal. Now the first point here is it supplying to any muscle here in the gluteal region? Remember, there will be no supply by the sciatic nerve in the gluteal region. Gluteal region में वो किसी भी muscle को supply नहीं करता है. Thank God, we don't have to learn anything. So in the gluteal region, you just remember these 2 points here. So it's passing through greater sciatic foramen, that to below piriformis. Then in the thigh, posterior compartment of the thigh, you'll be having muscles, and those muscles here will be the hamstring muscles, or simply you can call them as hamstrings. That will be supplied to semitendinosus, semimembranosus, and then bicep femoris, as well as one more muscle here, adductor magnus. Now let me tell you here, semitendinosus will be supplied by tibial nerve. I mean to say the tibial component of sciatic nerve. Semimembranosus is also supplied by tibial nerve. Whereas bicep femoris will be having two heads, long head and the short head. Long head is supplied by tibial nerve. Then what about the short head? Remember, the only option available here will be the common peroneal nerve. ये बहुत important है, आपके एग्जाम में already पूछा गया है. Common peroneal nerve will be supplying to the short head of bicep femoris. Now adductor magnus, again it will be having like two heads. Adductor muscle should be present in medial compartment, but a part of that is also coming behind. So therefore, in the medial compartment, that is known as adductor part, and behind in the posterior compartment, that will be referred to as the hamstring part. और अभी मैंने आपको golden rule में बताया था, adductor part in the medial compartment should be supplied by obturator nerve, whereas in the posterior compartment, hamstring part will be taken care by tibial nerve. Perfectly done, sir. That is about the posterior compartment of the thigh. And from here now the sciatic nerve will enter into the next landmark, that is your popliteal fossa. And right at the apex of the popliteal fossa, it's again dividing into two components. That is your tibial nerve. Another one will be the common peroneal nerve. First, let us deal with the common peroneal nerve. The common peroneal nerve is going towards the lateral side, and lateral side will be having fibula. Please remember this landmark exactly near the neck of fibula. It is going to divide. This is extremely important landmark. Near the neck of the fibula, it is going to divide into the deep peroneal nerve here and the superficial peroneal nerve. Let's deal with the superficial peroneal nerve. According to our golden rule, we know very well it is supplying to lateral compartment of the leg, and there in the lateral compartment of the leg, you'll be having two muscles, peroneus longus and peroneus brevis. The deep peroneal nerve will be supplying to anterior compartment of the leg, and there will be having one more peroneus, that is peroneus tertius, and that was recently asked in the exam. Direct question: peroneus tertius is supplied with which nerve? Deep peroneal nerve. And in the anterior compartment of the leg, you'll be having a muscle in front of tibia. Tibialis anterior muscle, and of course there will be having extensors. Extensor hallucis longus, extensor digitorum longus. Now, what is another nerve which is left out here? Tibial nerve. Now, remember, tibial nerve is going down, going down, going down, and then taking a turn, entering into the foot. And there it is dividing into lateral and medial plantar nerve. And this lateral and medial plantar nerve, they are the one which will be supplying to all the muscles of foot. Okay. Now come back here in the tibial nerve. Tibial nerve is supplying to posterior compartment of the leg. In the posterior compartment of the leg, you'll be having your calf muscle. In calf muscle, every medical student knows two muscles very well. That is your gastrocnemius. Gastrocnemius will be having like two heads, lateral head and medial head of the gastrocnemius, and then there will be soleus. Now there will be two small muscles here, plantaris and popliteus, and then the tibialis posterior. You can compare with the anterior compartment here, with the posterior compartment. There will be tibialis anterior here, so there will be tibialis posterior here. यहाँ पर extensors होंगे, तो obviously यहाँ पर flexor होंगे. Flexor hallucis longus and flexor digitorum longus. Done. Now, after learning about all the muscles here, let me tell you the MCQs here, my dear friend. Long head and medial head of gastrocnemius and soleus. They are like three muscles, and all these three muscles together they are referred to as tricepsurae. इन तीनों को कुल मिलाकर ट्राइसेप्सूरे कहा जाता है. And remember, soleus muscle, it is also referred to as the peripheral heart of the body. Why? Because it is the one which is going to pump the blood back into circulation. Okay. So while walking, what is going to happen? The calf muscles are going to contract and relax, and it is going to pump the blood back into circulation, and that is why it will be referred to as the peripheral heart of the body. Now, that is the reason why I was telling you in the beginning, sciatic nerve is very much important, sir. If you complete the sciatic nerve, you are done with superficial peroneal nerve, you're done with deep peroneal nerve, you're done with common peroneal, you're also done with tibial nerve. Like many nerves are actually done. All the many compartments are also completed here. Definitely, you can expect a question from there, sir. Now, apart from that sciatic nerve, all the major nerves and all. Now, welcome to the minor nerves, sir. Number one, from L1. From L1 here, we are getting two nerves here. That is ilio-hypogastric nerve and ilio-inguinal nerve. From L1 and L2, we'll be getting genitofemoral nerves. So this is from L1 and L2 here. And then from L2 and L3, we'll be getting lateral cutaneous nerve of the thigh. That is from L2 and L3. Now, let me tell you first of all about this lateral cutaneous nerve of the thigh. It is the one which is going to pass beneath the inguinal ligament here. I mean to say, sometimes it is getting compressed here. In which conditions it is getting compressed? Number one, obesity. Number two, pregnancy. Number three, wearing the tight clothing. So in obesity and pregnancy, the abdomen will be protruded there, and the lateral cutaneous nerve of the thigh will be actually compressed near the inguinal ligament. And it will lead to what? Numbness, tingling, burning, pain, or stabbing sensation on the lateral side of the thigh, and this condition is referred to as meralgia paresthetica. So what is the nerve involved in meralgia paresthetica? Lateral cutaneous nerve of the thigh. And what is the root value of that one? L2 and L3. So please keep this in mind. Another very important concept for your Ini-Cet exam is about the attachments on femur. Now, first of all, in this diagram, you're able to see this is ASIS here, and this one here will be the AIIS. Anterior superior iliac spine and the anterior inferior iliac spine here, sir. Now, anterior superior iliac spine, there will be one ligament attached here, and this ligament all the way will be going from here attached to the pubic tubercle here. That is inguinal ligament. Along with that, there is one muscle attached there, sartorius muscle. Anterior inferior iliac spine, there will be one muscle originating from here. That muscle will be rectus femoris muscle, sir. Rectus femoris one. Then in this diagram, you're able to see the gluteal tuberosity here, and the muscle that is getting attached onto the gluteal tuberosity will be the gluteus maximus muscle here. The muscle attached on gluteal tuberosity will be gluteus maximus, and it is the one which will be actually helping in extension at the hip joint and external rotation. Like when you are climbing up the stairs, extension at the hip joint as well as external rotation. Now on the greater trochanter, there will be gluteus medius attached posteriorly and gluteus minimus attached anteriorly here. Sir. And both of them are going to help in abduction as well as internal rotation. On the lesser trochanter, there will be iliacus and the psoas major attached here. And recently in your exam, this image was given and there was an arrow mark here like this. And on this arrow mark structure, what is the muscle attached here? Of course, it is lesser trochanter, iliacus and psoas major. Now, this one here will be your ischial spine, and here there will be a nerve taking a turn, pudendal nerve. Along with that, there will be artery here, so internal pudendal artery, and then there will be a vein here, internal pudendal vein. And we are going to remember these structures with the mnemonic as PIN. So the pin structures are going to take a turn around the ischial spine. The pudendal nerve, internal pudendal artery and vein, and the nerve 2 obturator internus are going to take a turn around the ischial spine, sir. Perfectly done. Now, what is the nerve which will be supplied to gluteus maximus? It will be supplied by inferior gluteal nerve. Whereas gluteus medius and gluteus minimus, these two are supplied by superior gluteal nerve. अब अगर मान लो कि superior gluteal nerve is injured, if the superior gluteal nerve is gone, then both these muscles will be actually gone here, sir, minimus and medius, and they are helping in what? Abduction at the hip joint. The person will not be able to walk properly, and he'll be walking by lurching on one side. That is known as lurching gait. And in lurching gait, what is the nerve involved? Superior gluteal nerve will be involved on one side. If the nerve is injured on both the sides, then what is going to happen? It will be waddling gait. Waddling gait, both the sides the nerve will be involved, and the person will be walking by waddling on both the sides like that penguin. The penguin, है ना? Waddling gait में ऐसा होता है. And what is the sign which will be positive here, sir? That is your Trendelenburg sign. That will be positive here. This is something like really important. Now the catching point here in the clinical question is, remember, if the hip is dropping on the left side, then it will be the contralateral nerve. That means the right superior gluteal nerve will be actually gone, sir. Please keep this in mind. If the hip is dropping on the left side, then the contralateral side, opposite side, that is your right superior gluteal nerve will be actually involved in Trendelenburg sign. Next concept here is about the tarsal tunnel here. In this tarsal tunnel, of course, there are all the structures passing here, and you have to remember them in order. Number one, there will be a tendon here. This will be the tibialis posterior tendon. One more tendon here will be the flexor digitorum longus, and this tendon here will be the flexor hallucis longus. There will be like 3 tendons. And from the very beginning, I'm telling you the nerve will be going here, then again dividing into 2 branches, lateral plantar nerve and the medial plantar nerve, supplying to all the muscles of foot there. What is a nerve? That is your tibial nerve there. And there is an artery here, and this is something very much important nowadays, and this is the posterior tibial artery. Posterior tibial artery, and you can clearly see the doctor is actually measuring the pulse with the help of that artery. Even that question was also asked in your exam. Okay. Now after that, what is going to happen here is the spring ligament. Now these are like certain image based questions you should be able to identify. Spring ligament kahan par hota hai? In this diagram, this big bone here will be your heel bone, calcaneum, and this is the navicular. Above you'll be actually having the talus. Now between the calcaneum and the navicular, there will be a ligament, that is spring ligament, and that is the reason why it is calcaneo-navicular ligament, also known as the plantar calcaneo-navicular ligament, the spring ligament. And it is one of the important support for the medial longitudinal arch. Now bifurcate ligament here, sir. You are able to see the 2 of them here. Yes, calcaneo-navicular ligament here and the calcaneo-cuboid ligament. These 2 bifurcate ligament over there. That also you have to remember here, sir. So that can be asked in your image based questions. So those images you got to remember. By this, we are done with the upper limb as well as the lower limb topic here, sir. Any doubts here? Yes, Dr. Shekhawat? Achha, okay, fine. Trendelenburg sign. Shall we go ahead now? So now once we're done with the upper limb and the lower limb, my dear friends, let us go ahead with the thorax. In thorax topic, the first thing is about the constrictions in the esophagus. Now esophageal constriction, there are totally 4 of them, sir. Now there'll be a bit of controversy here. Why? Because I think in surgery, it will be taught as 3 constriction here. But remember, there'll be totally like 4 esophageal constriction. One at the very beginning, the second one when arch of aorta is crossing that one, the third one when the primary bronchus will be crossing that one, and the fourth constriction will be when the esophagus is actually going to cross the diaphragm. And we need to learn where exactly you find this one here. Now, because in most of the classes, what is happening is the students are like, sir, in surgery, they taught us as only 3 constrictions will be present and all. That is the reason why I'm showing you with the reference, with the proof there. This is the screenshot from the 42nd edition of Gray's Anatomy, page number 1057, exactly, to be very specific. Yes, it is given like totally 4 constrictions are there in the esophagus. Now, the first one is at the origin where you have cricopharyngeus muscle, that is 15 centimeters from the incisors. Then when it is crossed by arch of aorta, it will be 23 centimeters from the incisors. Then the left main bronchus, 28 centimeters from the incisors. And finally, diaphragm, 40 centimeter from the incisors. So it's very, very clearly given in the Gray's Anatomy. There are like 4 constrictions, 15, 23, 28, and 40. Please remember that one. Now, the next thing is about the mediastinal surface of the lung. Now, on the mediastinal surface of the lung, let me just clarify first of all, let me give you a disclaimer. This diagram will not be given in the exam with the structure. Actually, they will give you this diagram without the structure. And you have to identify that this impression is due to what? Something like that. Now, the first thing, let me tell you, esophagus is actually going to pass in the middle. Now, because esophagus is passing in the middle there, remember its impression will be present on both the lungs. The impression of esophagus will be there on both the lungs here. So first you'll be able to find the impression for esophagus here. Then of course, if this is your left lung over there, this is the impression for your heart, and from the heart begins your ascending aorta here, and this one is very much important, that is the impression for arch of aorta. And then of course you'll be having your descending aorta over here. Fine. The arch of aorta is actually going to give rise to those 3 branches and all those things we know very well. Now, once you are done with these impressions, if you're able to identify that one here, sir, welcome to the mediastinal surface of the right lung here. Yes. Again, the same thing here towards the right lung. I told you when we learned about the azygous vein is actually, the meaning of that one is, it is single, unpaired. Azygous vein will be single and present towards which side, sir? Right side. Now, on the right side here, this is the impression for your azygous vein. And then it is going to ascend up an arch here. So there will be arch of azygous vein here. And then finally it is going to go and drain into superior vena cava. And we know that superior vena cava is formed by right and left brachiocephalic vein. So this one has to be the right brachiocephalic vein here. No doubt about that. And superior vena cava will finally go and drain your blood into your heart. And to be specific, that is your right atrium there. In this manner, you can remember. And I told you the impression for esophagus will be in the center. And therefore, esophagus passing in the center. Therefore, its impression is there on both the lungs, right lung as well as the left lung. That is also another important concept to be remembered here, sir. Now, your Ini-Cet examiner is very much, fan of this azygous system also. Many times the question will be asked from here. Now, in this diagram, you're able to see this is superior vena cava here. And it is going to be formed by the union of the right brachiocephalic vein and the left brachiocephalic vein here. And below here, this is your inferior vena cava. Fine. What about the azygous vein? Azygous vein is actually unpaired, single, and it is going to pass, yes, from the right side. So it's going to move up, 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 and then take a turn, and then it is going to drain into the superior vena cava. Now what you have to learn here is that, what about these veins? The veins on the right side here, so the posterior intercostal vein. All these veins are nothing but the posterior intercostal vein here, sir. On the right side, they are going to drain where? We got to learn about that one. Now remember, the first vein on the right side is going to drain into the right brachiocephalic vein. No doubt about that. The second, third, and the fourth vein, together they are going to join and form right superior intercostal vein. And the right superior intercostal vein will go and drain into what's an azygous vein. You can very clearly see it's going and draining into azygous vein there. After that, no need to remember the number 5, 6, 7, 8, blah, blah. All of them will drain into azygous vein only. Now welcome onto the left side here, sir. Now on the left side, again the same thing. The first vein is draining into what? It is draining into the left brachiocephalic only. Now please be very, very careful here. Second, third, and the fourth vein together, again they are going to form the left superior intercostal vein. Already asked in the Ini-Cet exam, it will go and drain into what? It will drain into the left brachiocephalic vein, sir. On the left side, you don't have the azygos vein. On the left side, you don't have the azygos vein. So remember, on the left side, it's going and draining into the, yes, left brachiocephalic vein. So after that, another 4 veins will be draining into accessory hemiazygous vein. That will also come and drain into azygos. And another few veins here will be draining into hemiazygous vein. That will also cross and drain into the azygous vein. The hemiazygous and accessory hemiazygous will be finally going and draining into the azygous vein. So perfect. Am I very clear here? So already, multiple times the question has been asked from here. Left superior intercostal vein will be draining into the left brachiocephalic vein. Please remember that one. Now, once you are done with this one, these are all the high-yield topics to be learned or revised in the thorax. And now, my dear friends, welcome to the next topic, that is abdomen topic. In the abdomen topic, of course, we need to learn about the inguinal canal. Very much important one. Now, in this diagram, you know very well in the, in our main videos and in our regular classes, we have learned about the anterior abdominal wall. There are totally like 8 layers. Out of that 8 layer, this is the 6th layer, that is transversalis fascia. Now in this transversalis fascia, you're actually having a defect. There is an oval shaped opening here, and this opening is referred to as deep inguinal ring. Then in the layer number 3, that is external oblique aponeurosis here, there will be a triangle shaped opening here, and this one here will be the superficial inguinal ring. Now, in the middle, you're actually having 2 layers here, so that is your internal oblique and transversus abdominis. Join them together, and together they are going to form your conjoint tendon. So conjoint tendon, also known as the falx inguinalis, it is made up of internal oblique plus transversus abdominis. First, you try to learn these 3 points here. Let us repeat that again. Come on. Deep inguinal ring is present in which layer? Transversalis fascia. The superficial inguinal ring is present in which layer? External oblique. And then conjoint tendon is formed by dash and dash, that is internal oblique as well as transversus abdominis. Now join the deep inguinal ring with the superficial inguinal ring here. Join the deep inguinal ring with the superficial inguinal ring here. And together they are going to form a canal. That canal is nothing but your inguinal canal. Now the first thing here, we need to learn what are the boundaries of this inguinal canal. Now inguinal canal is from here to here. Now what is present anteriorly? You can very clearly see in front of the inguinal canal there will be external oblique and the internal oblique here. What do you have posteriorly? Posteriorly there will be conjoint tendon here and transversalis fascia here. Anterior done, posterior done. What do you have superior? Above that one. Above this one you'll be having the internal oblique as well as the transversus abdominis here, because they're arching from above and going and forming the conjoint tendon. And what do you have below? Below the inguinal canal there will be inguinal ligament. Now, once you are done with all the boundaries of the inguinal canal, what are the contents? So remember, in male, you'll be having spermatic cord passing from here. Why? Because the testis is going to descend from here only, right? So the spermatic cord is passing from there along with ilioinguinal nerve. And in the female, there will be round ligament of uterus passing from here along with the same nerve, that is your ilioinguinal nerve. So in one diagram, we are actually done with all the points revised about the inguinal canal. So I hope you are quickly revising. Everything is like freshen up in your mind right now, sir. Now another very important topic for your Ini-Cet exam, openings of diaphragm. There are 3 major openings in diaphragm. The vena cava opening, that is found in the central tendon. We can clearly see there. And then the next one will be esophageal opening, found in the muscular part here. And then between the right and left crus of the diaphragm, you'll be able to find the aortic opening there. You also have to remember they are present at which level. Vena cava opening will be at the level of T8. Esophageal opening will be at the level of T10. Aortic opening will be at the level of T12. I hope you all remember that very famous mnemonic, Voice of America, T8, T10, and then there will be T12. Now, of course, there is an opening here. If there is opening present, then you have to also learn about the structures passing from here. So what are the structures passing from the vena cava opening here? Of course, there will be inferior vena cava. Write that and forget about that one, sir. Vena cava opening, inferior vena cava. They'll never ask you. Along with the inferior vena cava, there will be right phrenic nerve passing from here, sir. Right phrenic nerve passing from here. Now from the esophageal opening, of course, esophagus will be passing from here, sir. And along with the esophagus, remember, there will be vagus nerve. Along with the esophagus, there will be vagus nerve here. And then aortic opening, what is going to pass from here? Of course, aorta. Along with the aorta, there will be thoracic duct passing from here, that largest lymphatic. Along with that, even the azygous vein is also going to pass from here. So that is about the major openings of diaphragm. You have to remember all the openings, they are present at which level, and what are the structures passing from there. So now, yes, recently they have also asked about the Calyx triangle also. Can you please look at this diagram and tell me where exactly you have the Calyx triangle? In between what? What are the boundaries of this one? So please remember the C for Calyx triangle and remember the three C's here. Okay now. So one of the C here will be the cystic artery here. Another C here will be the common hepatic duct here. Okay. And then another one will be the cystic duct here, sir. Now between these three, there is your cystic artery here, the common hepatic duct and the cystic duct here. Between these three, the triangle found here will be the Calyx triangle. So Calyx triangle, remember C for three C's over there. Now in this diagram, you are able to see first of all the stomach in the center here, and this one is your liver. Liver comes towards the right here. After that, rotation of the foregut 90 degrees, and this is the spleen here, which is coming towards the left here. Now, right in front of the liver, there is a ligament here. This ligament here will be the falciform ligament. And between the liver and the stomach, there will be one more omentum, and that omentum is actually lesser omentum here. But it is not attached to the liver here. Why? Because we are taking the section a little bit below. That is a free margin of the lesser omentum. Free margin of lesser omentum here. Now, between the stomach and the spleen, of course, there will be gastrosplenic ligament. And between the spleen and the kidney behind, that will be splenorenal ligament. Splenorenal ligament here. Perfect. Now, what is happening here, after rotation of the gut, there will be a little bit of space present over here behind the stomach, and this one will be referred to as lesser sac. And this lesser sac, it is also known as the omental bursa. And the remaining space over here will be referred to as the greater sac here, sir. This is the greater sac. Now, this lesser sac here, this entire lesser sac here is connected with the greater sac with the help of this opening here, and this opening here will be the epiploic foramen. Okay, now, so this one here will be the epiploic foramen, or else it is also referred to as omental foramen. Also, it is referred to as the foramen of Winslow. Now, you got to remember the boundaries of this epiploic foramen, sir. Now, what do you have right in front of the epiploic foramen here? You can clearly see in front of the epiploic foramen, you're having free margin of the lesser omentum. And in that free margin of the lesser omentum, there will be portal triad. And the portal triad will consist of portal vein, the proper hepatic artery, and the bile duct. The portal vein, the proper hepatic artery, and bile duct is present in the free margin of the lesser omentum. Then what do you have behind the epiploic foramen here? Behind the epiploic foramen, there will be inferior vena cava. Inferior vena cava. That is about the anterior boundary and the posterior boundary. What do you have superiorly and inferiorly? Now look here. Between the liver and the stomach here, this one is lesser omentum. And this here will be the free margin of the lesser omentum here. This is the free margin here. And I told you epiploic foramen is present behind the free margin here, sir. Epiploic foramen कहाँ पर होता है? इसके पीछे होता है. Now, above that, what do you have? Above the epiploic foramen, there will be liver. But which lobe of the liver was asked in the exam? Please remember it is the caudate lobe of the liver. Caudate, not quadrate lobe of the liver. It is caudate lobe of the liver. And below here will be actually the duodenum. Of course, the first part of the duodenum. First part of the duodenum, sir. Perfectly done. Now, once you are done with this one here, let us go to the next topic. That is pelvis and perineum topic. And of course, your Ini-Cet examiner is also interested about the extravasation of the urine. So you have to remember two cases here. Number one case here will be the straddle injury. Now, what do you mean by the straddle injury here? Riding the bicycle on the bumpy road. And remember, in the straddle injury, the urethra that will be ruptured here will be the bulbar urethra. Now, for example, if a person falls in the manhole, okay, the important key word that you have to remember here is pelvic fracture. In your exam, in the clinical question, they'll be giving you this word pelvic fracture. You have to find this keyword. Straddle injury and the pelvic fracture. And in pelvic fracture, the urethra that will be ruptured will be the membranous urethra. In pelvic fracture, membranous urethra will be ruptured, sir. Now in this diagram, you can clearly see here the urethra which is passing through the prostate gland here, prostatic urethra. Then you'll be having the membranous urethra, and this one here will be the bulbar urethra. If membranous urethra is ruptured here, the urine will be going out into the deep perineal pouch only. So this one here will be the deep perineal pouch. And from here, the urine can also go into this space here. And this space here surrounding that neck of the urinary bladder there is nothing but the space of Retzius. Space of Retzius, fine. अगर मान लो बल्बार यूरेथ्रा रप्चर होता है, if the bulbar urethra is ruptured, the urine will go into the superficial perineal pouch, the urine will also go into the scrotum here, the urine will also go into the penile shaft, as well as the urine will also go into the anterior abdominal wall. Is it okay? So let's see here. As I told you, the keyword straddle injury, which urethra will be ruptured? Bulbar urethra. And pelvic fracture, which urethra will be ruptured? Sir, membranous urethra will be ruptured. If bulbar urethra is ruptured, the urine is going almost like every way this, है ना? Superficial perineal pouch, the scrotum, the penile shaft, as well as the anterior abdominal wall. If membranous urethra is ruptured, then the urine will go into the deep perineal pouch as well as the space of red CS. Now, where is the urine going? We know that very well. But in the exam, they're also asking where is the urine not going? I mean to say the urine cannot extravasate. Like urine cannot go into the thigh due to which fascia? Fascia lata. The urine cannot go into the deep perineal pouch because there is a membrane present there. Which membrane? Perineal membrane. And yes, of course, it cannot go into the ischiorectal fossa due to the Colles fascia. So you have to remember the reason why it is not passing from there, sir. Why it is not able to go into that one, guys. Now in this diagram, you are able to see this one here will be the ischiorectal fossa here. This is the ischiorectal fossa here. Fine. Now if that is the ischiorectal fossa, what is going to form the lateral boundary of that one? Laterally, you'll be able to see the obturator internus muscle here. And this one here is obturator internus muscle. And this one here will be the ischial tuberosity on which you and me, we are sitting right now. What is going to form the medial boundary? This one here will be the levator ani muscle, sir. And the external anal sphincter. So this is levator ani here, and this is the external anal sphincter muscle here. So ischiorectal fossa, on the lateral side you're having obturator internus, on the medial side there will be levator ani and external anal sphincter muscle, guys. That is the boundaries that you have to remember. And then anteriorly, of course, there will be a membrane, that is your perineal membrane, and posteriorly you'll be having the sacrotuberous ligament, the ligament between the sacrum and ischial tuberosity. Now what is the content? Of course, you're able to see it is filled with fat here. Apart from the fat, अगर आप इसको ध्यान से देखोगे, on the lateral wall here, you'll be able to appreciate one canal, and this canal here will be the pudendal canal, also known as the Alcock's canal. And in this pudendal canal, there will be pudendal nerve, there will be pudendal artery and veins, and internal pudendal artery and vein. So therefore, in the contents, you'll also have the pudendal canal here, that is also referred to as what, guys? Alcock's canal. Another name of this one is Alcock's canal, and it will consist of what? Pudendal nerve along with the internal pudendal artery and vein. And along with that, you'll also have inferior rectal nerve and the vessels, as well as the posterior sacral nerve and vessel, and homologous to that in the female, that will be the posterior labial nerve and the vessels, guys. All this will be the contents of your ischiorectal fossa. Now once you are done with this one, welcome to the internal iliac artery. Internal iliac artery, another important PYQ for your Ini-Cet exam. Many times the question has been asked from here. The internal iliac artery is divided into two divisions here. One is your anterior division, another one will be the posterior division. And I request you to remember the branches of only and only the posterior division. Why? What is the reason? Now remember, the posterior division will be giving only three branches, and those three branches you are going to remember as SIL branches. S for superior gluteal artery, I for iliolumbar artery, L for the lateral sacral artery, sir. Superior gluteal artery, I for iliolumbar artery, and L for lateral sacral artery. Very good, Dr. Imran. And once you are done with this one, if you still have energy and time, then you learn the branches given by anterior division. There are like many of them. So learn it smartly here. Only learn the three branches given from the posterior division. Why? Because always in your exam, they're giving the same question. All of the following are the branches from the posterior division except one. So you can easily rule out that one, sir. आप आराम से उसको rule out कर सकते हो. Okay ना? So now after completing upper limb, lower limb, thorax, abdomen, pelvis and perineum, welcome to the most important topic. And of course, this is the last one here, sir. Welcome to embryology. Okay. Now welcome to the embryology part here, sir. Now my dear friends, remember in embryology, one small concept. Already questions has been given from here. What about this primordial germ cells? See, primordial germ cells, they are the one which are going to form the male and female gametes. They're going to form male and female gametes. So if they're going to form the male and female gamete, of course, these cells have to migrate and go to the genital ridge. Why? Because genital ridge is the one which is actually going to form what's a gonads. If you have learned this, very good. Otherwise, learn it right now. Genital ridge is the one which is going to form the gonads. The male gonads testis and the female gonads ovaries are derived from genital ridge. So of course, the primordial germ cells has to migrate all the way to the genital ridge, and there it is actually going to form the male and female gamete. But you have to remember the entire traveling. I mean to say from where it is going to travel and at what time. First point already asked in your exam, primordial germ cells are produced from where? Answer, epiblast. When it is produced, second week. From there, they will go to yolk sac by fourth week. Okay, and then from there, they are going to migrate to genital ridge by the end of the fifth week here. ये भी सवाल आपके एग्जाम में पूछा गया था. So they are migrating from the epiblast to the yolk sac, and from the yolk sac, they'll be finally going to the genital ridge. Now, sometimes there will be, what will be happening here? This is the normal migration. Thank God, like this, it happened in your body and my body, and we are normal people. In some unfortunate babies, it will be abnormally migrating, and there will be abnormal migration of primordial germ cells to the neck. And they are migrating to the neck. It will lead to craniopharyngeal teratoma. It will lead to craniopharyngeal teratoma. Similarly, if it is going to abnormally migrate to the sacrum, then it will lead to sacrococcygeal teratoma. Another reason for the sacrococcygeal teratoma will be the persistence of the primitive streaks. Persistence of primitive streak. This has been given or asked in your Ini-Cet exam as an image-based question also. So please take care about that one. One more question asked in your Ini-Cet exam is location of the SRY gene. SRY gene, where it is located? Remember, it will be located on the Y chromosome, and that too on the short arm. The distal end of the short arm of the Y chromosome. Your SRY gene will be located there, sir. Now welcome to this diagram here. This diagram is actually the transverse section of the embryo. In the transverse section of the embryo, this green colored highlighted structure will be the notochord. And above the notochord, this one here will be the neural tube. On either side of the neural tube, you'll be able to appreciate the neural crest cells. This was given in the image-based question. First, you people try to identify everything here. Then later on, I will tell you. Then apart from that, yes, in this diagram, you're able to see the outermost layer here. This one will be the ectoderm here. The inner layer here, this one will be the endoderm here. And in the middle, you'll be actually having the mesoderm here, sir. So there'll be ectoderm, endoderm, and the mesoderm. The mesoderm present over here will be actually divided to three parts here. There will be paraxial mesoderm, and then there will be intermediate mesoderm, and then you'll be having the lateral plate mesoderm. Paraxial mesoderm, intermediate mesoderm, and the lateral plate mesoderm, sir. Now, out of this, remember, the intermediate mesoderm is the one which is going to form nephrogenic cord. From the name itself, you're able to understand it is going to form the kidney. And another one, it is also going to form genital ridge. And genital ridge is the one which is going to form gonads. So in short, we can say that nephro, uro, genital, so urogenital system. Intermediate mesoderm is the one which is going to form your urogenital system, sir. Now welcome to the paraxial mesoderm. Paraxial mesoderm is going to form a spherical ball-like structure known as somites, sir. Now this somites will again have three parts in that one. One will be the dermatome. It is going to form dermis of back of the body. And then the sclerotome. Sclerotome is going to form the skeleton, but the axial skeleton. And then myotome. Myotome is actually the one which is going to form the muscle. But remember, again it is divided into two categories here, epiaxial and hypoaxial myotome, sir. Epiaxial and hypoaxial, remember, epiaxial is the one is going to form the true back muscle, and hypoaxial myotome is the one which is going to form the muscles of your limbs, upper limb, lower limb, and then intercostal muscle and the abdominal muscle. So all these are going to form from the hypoaxial myotome. Now, whatever we have learned here, everything else will be actually derived from the lateral plate mesoderm here, sir. Okay, now, so you can dump it here. As I told you, dermis of the back from somite. So therefore, dermis of front of the body, lateral plate mesoderm. Axial skeleton from the paraxial mesoderm. The appendicular skeleton will be from the lateral plate mesoderm. And then whatever muscles I told you here, all this will be like your skeletal muscles here. Whereas the smooth muscle and cardiac muscles are actually derived from the lateral plate mesoderm there. I hope this concept is like perfectly clear. Now, apart from that, in your Ini-Cet exam, remember the neural tube and the neural crest cells derivatives are very much important here. So let's see the neural crest cells derivatives here. First, you should be able to identify here. The neural crest cells will be located on either side of the neural tube here, sir. The neural crest cells are located here. It was given as an image-based question. This will be the neural crest cells. Fine. Now remember, neural crystals are the one which are going to form your peripheral nervous system. So all the ganglions as well as the enteric plexus is formed by the neural crystals. This is something important already given in the exam. Schwann cells are also going to form from the neural crystals. In the adrenal gland, we'll be having two parts. Outer part is cortex, inner part is medulla. Adrenal medulla will be derived from the neural crystals. And this is also asked in the exam, parafollicular cells or C cells. Please remember very carefully, they are the one which are present in your thyroid gland and derived from neural crystals. Okay. And after that, melanocytes, most of the skull bones, the dentine, okay, and the pharyngeal arch cartilages here, the dermis of head and neck, okay, and all these parts which are related with the head and neck are derived from the neural crystals. Now in Ini-Cet exam, even this was also asked, a conotruncal septum. It is made up of two septum here, spiral septum and the bulbar septum. These two septum together it is referred to as conotruncal septum, guys. Now once you are done with the derivatives of neural crystals, welcome to neural tube defects. If I just give you a simple diagram here, for example, if this is your neural tube here, neural tube is the one which is going to form your brain and the spinal cord. Above there will be one opening here and below there will be one more opening here. Of course, that is known as neuropore. So this one will be the anterior or cranial neuropore. Anterior or cranial neuropore, and this one here will be the posterior, or it is also referred to as the caudal neuropore. Now normally what should happen, do we have any opening in the brain here right now? No, that means it has to be closed. Remember, this will be closing on 25th day, whereas the caudal neuropore will be closing almost by 28th day. 25th day and 28th day, it has to be closed. In some unfortunate babies, the cranial neuropore will not be closed and it will lead to a condition known as anencephaly. If the caudal neuropore is not closed, it will lead to a condition known as spina bifida. Spina bifida. And welcome to this picture here. In this picture, you're able to find the anencephaly here. Along with the anencephaly, even there is a bony defect of the spine. The vertebrae are not closed properly over there. The spinal cord is visible from here. So remember, this condition is actually referred to as the craniorachis. That condition is known as craniorachis. Is it okay? So there will be anencephaly here and the spina bifida. Yes, along with the anencephaly, if there is a spinal defect, the defect of the spine there is nothing but the craniorachis, guys. Now, once you are done with this one, welcome here to the cleft and the pouches. We know that the cleft will be derived from ectoderm, ectodermal cleft, and the pouches will be derived from endoderm, and that will be the endodermal pouches. Cleft will be derived from the ectoderm, ectodermal cleft, and then endodermal pouches. There are four ectodermal clefts. The first cleft is the one which is going to form external acoustic meatus. Along with that, it is also going to form the outer layer of the tympanic membrane. Outer layer of the tympanic membrane, sir. Fine. And fine. And after that, what is going to happen? The second and the third and the fourth cleft, these three clefts are actually obliterated. They are closed. Nothing is formed from there. Now, why it is closer? Why? Because you can very clearly see the second arch in the middle here. The second arch here is growing faster and it is going to close that one. So sometimes what is going to happen, there is a space formed here. This space will be referred to as your cervical sinus. Cervical sinus here. Now, cervical sinus has to be normally closed here. But if it is not closed here, if it is remaining, if it persists, then there is a formation of cyst here. And that cyst is actually referred to as the branchial cyst. And that branchial cyst, remember, it is also, yes, if it is going to communicate with the outside, that is also referred to as branchial fistula. Whatever it is, if they are asking you in the exam, branchial cyst or branchial fistula is due to what? Persistence of the cervical sinus. Now, similarly, what about the endodermal pouches here? The first pouch is the one here, which is going to form the medullary cavity along with the auditory tube, along with the inner layer of tympanic membrane. The second pouch is the one which is going to form the palatine tonsil. It is going to form epithelium of the palatine tonsil. The third and the fourth pouch here, it is going to form the parathyroid gland, the superior inferior parathyroid gland. But remember, the third pouch with the rhyming word you remember as thymus. Third pouch is going to form the thymus along with the inferior parathyroid gland, whereas the fourth pouch is going to form the superior parathyroid gland. Sir. Superior parathyroid gland. Is it okay? Now, once you are done with this one here, yes, I hope you all have heard about the DiGeorge syndrome, guys. In DiGeorge syndrome, mainly which pouch will be involved? Remember, the third pouch will be involved, sir. Mainly the third pouch will be involved. So there will be thymic hypoplasia, and parathyroid gland is also not forming there. So therefore, it will lead towards a hypocalcemia. Calcium regulation will be disturbed there. Now, another hot favorite topic of Ini-Cet examiner is development of the diaphragm. Development of diaphragm will occur from four structure. Even this image was also given in the exam, sir. Okay, this image was given there. Now, in the development of diaphragm, please remember, number one, the muscle part, muscles of the diaphragm will be derived from where? They are derived from the body wall mesoderm, also referred to as cervical somites. Please remember this word cervical. This will be confusing during the exam, sir. Why? Because students will be thinking diaphragm is present over here. How can cervical somites formed here? Remember, it's actually cervical somites. And then what about B here? Remember, if this was your esophagus here, okay, then the peritoneum will be coming here, enclosing this one and going back there. Double layer of peritoneum which will be formed here will be known as mesentery. And that is on the dorsal side, dorsal mesoesophagus, enclosing the esophagus. That is also contributing for the formation of your diaphragm. And this big septum here is nothing but the septum transversum, and that is going to form the central tendon of diaphragm. And now welcome to the most important thing. Above lungs here, below the abdominal viscera, covered by pleura, covered by peritoneum here, pleuroperitoneal membrane on both the side. So this one is pleuroperitoneal membrane. This one is pleuroperitoneal membrane on either side. Now, sometimes in some unfortunate babies, the pleuroperitoneal membrane will be absent. And if that is absent, then what is going to happen? All that loops of intestines are going to herniate into the thorax, and that is nothing but congenital diaphragmatic hernia. Congenital diaphragmatic hernia will occur due to the absence of pleuroperitoneal membrane. Absence of pleuroperitoneal membrane, sir. Now, welcome to development of arterial system, sir. All these are like very, very high yield topics for your Ini-Cet exam, sir. Listen here carefully. Now, in total, you'll be having like, 6 pharyngeal arch arteries. Okay, now there'll be like 6 arch arteries on one side and 6 arch arteries on the other side. So you'll be able to find like, 6 arch arteries, like first, second, third, fourth, the fifth, and the sixth arch artery here on one side, on the other side. Now, what is happening with the first and second one? The first and second arch artery will actually degenerate, sir. But still you're having the remnant. Now, what is the remnant of the first arch artery? The remnant of the first arch artery will be the maxillary artery. Okay. What is the remnant of the second arch artery? The second arch artery remnant here will be the stapedial artery. Stapedial artery, and one more artery that you have to remember here will be the hyoid arteries. So stapedial artery and hyoid artery are the remnants of second arch artery. Now, what about the third arch artery? Remember, third arch artery, it is the one which is going to form your carotid arteries. So the proximal part, of course, it is going to form the common carotid artery, and the distal part is the one which is going to form your internal carotid artery. Okay, external carotid artery is just given like a bud from there. Fine. Now welcome to the most important one, fourth arch artery. The fourth arch artery on the left side, only on the left side. Left fourth arch artery, it is the one which is going to form arch of aorta on the left side. So then what about the right side there? On the right side, the right fourth arch artery is contributing for the formation of right subclavian artery. Right subclavian artery. I'm not telling only this one is going to form. Remember, right subclavian artery is going to form from 3 structures. One of them will be the right fourth arch artery. So right fourth arch artery, right dorsal aorta, as well as the right seventh cervical intersegmental artery. All of them will be contributing for the formation of right subclavian artery. And as you all know very well, out of all the arches, remember the fifth arch will completely disappear here. So nothing will be derived from here, and there is no remnant also. Now, what about the sixth arch? Sixth arch is the one which is going to form pulmonary arteries here. And not only pulmonary artery, what is going to connect the pulmonary artery with arch of aorta? That is nothing but ductus arteriosus. Even that is also derived from the left sixth arch artery. So with the help of this one simple diagram, you have to actually remember about the derivatives of all the arch arteries here. Now, once you are done with the derivatives here, one important MCQ, my dear friend. On the right side, what is going to happen? Nothing formed from here and nothing formed from here. That is why on the right side, the right recurrent laryngeal nerve is going to move up and take a turn around the right subclavian artery. Whereas the left side, what is going to happen? Ductus arteriosus will be formed here. And after birth, it will be closed to form ligamentum arteriosum. And that is not allowing the left recurrent laryngeal nerve to go up. Okay, so it is going to take a turn around the arch of aorta only. So therefore, on the left side, the left recurrent laryngeal nerve is more longer when compared to the right recurrent laryngeal nerve. And why it is longer? Because of which arch? That is the left sixth arch artery. It is having the longer course because of the left sixth arch artery. Now, what is this condition that is abnormal right subclavian artery? अभी मैंने आपको बताया था कि right subclavian artery will be derived from the right fourth arch artery. Now, for example, if the right fourth arch artery will be obliterated and this caudal part here is actually persisting, it is remaining, then what is going to happen? Instead of the right subclavian artery forming from here, abnormally the right subclavian artery will be forming from here. So first, aram se slowly you learn what is the cause. So what is the cause for the formation of abnormal right subclavian artery? Because of the obliterated right fourth arch artery. Right fourth arch artery will be obliterated. And then persistence of the caudal part of the right dorsal aorta and right seventh cervical intersegmental artery. इसीलिए अब क्या होगा? Now this artery is going to come from behind the trachea in the esophagus here. You can clearly see that abnormal right subclavian artery is coming from behind the trachea and esophagus and it is compressing them. And this condition here will be the dysphagia lusoria. Oh. Are you understanding here? So abnormal right subclavian artery, that is dysphagia lusoria, is because of the obliterated right fourth arch artery. Right fourth arch artery is obliterated, sir. Now welcome to the next one here in the embryology, that is gut embryology here. In gut embryology, nowadays they are asking like many questions, sir. For example, if this is your developing embryo here and it is already folded, craniocaudal fold here. And this one here will be the body wall of the embryo. And the body wall of the embryo will be derived from where? It is derived from ectoderm. Now, what about the endoderm here? Endoderm is the one which is going to form your gut. The foregut and the midgut and the hindgut here, sir. So this one here will be the foregut, then there will be midgut, and then you'll be having the hindgut here. Midgut will give rise to an extension here, that is vitellointestinal duct here. And hindgut will give rise to an extension known as allantois here, sir. Okay, now first of all you have to remember that this one will be actually your future umbilical cord here, sir. Now in your exam nowadays they're asking like what will be the contents of the umbilical cord. Number one, you are able to see there vitellointestinal duct. Number two, you are able to see there, that is allantois. Number three, that you are not able to see there will be a jelly like substance known as Wharton's jelly. And then there will be right and left umbilical artery, whereas there will be only and only left umbilical vein present over there. Please be careful with this one. Recently ये भी आपके एग्जाम में पूछा गया था. दोनों भी arteries होती हैं, but when it comes to the vein, there will be only the left umbilical vein present. Now welcome to the MCQs here. Now sometimes what is going to happen, in normal people like you and me, what should happen is vitellointestinal duct should be actually closed, sir. But sometimes what is going to happen is it is going to remain persistent. अगर ये persistent रह जाएगा तो whatever meconium will be present there, it is going to come out of the umbilicus. So if you are able to see the meconium coming out of the umbilicus, what is the defect? The defect is persistence of vitellointestinal duct. Now sometimes what is going to happen, distal part will be gone, only the proximal part is persisting here, sir. Proximal part is persisting and that is referred to as Meckel's diverticulum. Meckel's diverticulum, sir. So these two important things you remember from here. Now what about this hindgut? Hindgut में क्या होता है? I told you the outer body wall is derived from ectoderm and this entire gut here will be derived from endoderm. So obviously in the middle what you have? Mesoderm, and that mesoderm is going to separate this hindgut from allantois. So let me just draw the last part here. Hindgut will be separated apart. That is going to form your rectum, anal canal. And allantois will also be separated here, and that is going to form urogenital sinus, and they are separated by the mesoderm in the middle. Now listen to this very much carefully here. So now this is the urogenital sinus here. The cranial part of this one here will be referred to as urachus. This is urachus. Now first point is urogenital sinus is the one which is going to form what? Urinary bladder. It is going to form entire urinary bladder except for the trigone wala part, and trigone is derived from Wolffian duct. We know that very well. Acha, if that is going to become the urinary bladder, then what about urachus? Urachus will be closed to form a ligament. That ligament will be the median umbilical ligament. It is N, median umbilical ligament here, sir. Okay. So what is median umbilical ligament? It is nothing but the remnant of what? Okay, it is actually the closed urachus. Now, in some babies, unfortunately, what is going to happen? ये urachus close नहीं होता है. If the urachus is not closed there, then what is going to happen? Whatever urine will be present in the urinary bladder here, that urine will start coming out of the umbilicus here. And that condition is referred to as weeping umbilicus. So now tell me, if urine is coming out from the umbilicus, then that is due to the defect in urachus, persistent urachus. If urine is coming out from the umbilicus, it is due to persistent urachus. If suppose meconium is coming out of the umbilicus, it is due to persistent vitello-intestinal duct. I hope the concept is like crystal clear. Yeah, absolutely correct, Dr. Imran, Dr. Bella, absolutely correct there. Fine. So all these conditions has been asked in your exam. Please take care about that one. Now please look at this diagram here. Now in this diagram, yes, my dear friends, in this diagram, you're able to see this is the esophagus here, the stomach here, and the duodenum. I mean to say this one will be your foregut here. You have your gut, the foregut there, esophagus, stomach, and duodenum are there. Now, right in front of that one, there will be a double layer of peritoneum here. This entire double layer of peritoneum will be ventral mesogastrium. And then there will be a double layer of peritoneum behind here, and that will be referred to as the dorsal mesogastrium. First, you remember that there will be ventral mesogastrium and then there will be dorsal mesogastrium. Now you can very clearly see liver develops in which mesogastrium, which mesentery? Ventral mesentery. If liver is forming here, right in front of the liver, there will be a ligament there. That ligament will be the falciform ligament. And between the liver and the stomach, there will be omentum. That omentum will be lesser omentum. Lesser omentum. All this will be derived from where? They are derived from ventral mesentery only. And not only that, the liver is covered by the triangular ligament and the coronary ligaments. All these structures are derived from the ventral mesentery. Easy to remember. I'll repeat once more here. Liver is actually forming in the ventral mesentery here. Right in front of the liver, there will be a ligament, falciform ligament. Between the liver and the stomach, there will be a ligament. That ligament will be what, guys? Lesser omentum. That is actually lesser omentum. And then the liver is actually covered by the triangular ligaments as well as the coronary ligaments, and all of them will be derived from your ventral mesentery. And now welcome to the dorsal mesentery. Now in the dorsal mesentery, you can very clearly see there is a ligament between the stomach and the diaphragm here. Gastrophrenic ligament, gastrosplenic ligament, splenorenal ligament, and then the greater curvature will be attached with what here? The greater omentum. Greater omentum. All these ligaments will be actually derived from the dorsal mesentery, dorsal mesogastrium, and that also has been asked in your exam many a times. So please take care about this one here. Is it okay? And by this, we have discussed about the embryology part also here. So all the topics, all the very, very high topics in embryology has been completed here, sir. Okay. And by this, my dear friends, we are actually done with the entire discussion of your entire anatomy. All the high yield topics which are very, very much required for your Ini-Cet exam has been completed in detail. So neuroanatomy, head and neck, upper limb, lower limb, all the nerves, the ulnar nerve, median nerve, radial nerve, as well as the sciatic nerve and all, as well as the thorax, abdomen, pelvis and perineum, as well as embryology. All the topics are completed here. So I request you to revise this part 1 and part 2 together before going to your exam, guys. All the best. God bless you all. Thank you.